So my name is Chris Helms, and I'm a nurse practitioner. I have a kind of a varied background. My background is actually in cardiothoracic surgery, and after moving to Australia, quite quickly discovered that being a cardiothoracic surgery nurse practitioner is not going to be the culmination of my career, and I went back into general practice and have been happy ever since. So I will just give you a couple warnings about today's presentation. If you've come here to do a practical demonstration of ear syringing, I'm sorry. And if you walk out right now, I won't be offended. That's perfectly okay. Unfortunately, from a lot of different perspectives, from a medical legal perspective, also from a look how many people are in here. To get that number of ear irrigation machines in this room, there'd be a lot of water. It would be a mess. People would have wet clothing. It's just not a good look for a conference. So yes, I just want to let you know that there's not going to be that component. The other thing I just want to warn you about is that I do speak quickly when I'm nervous. So if I do speak quickly, just tell me to slow down. I will not take offense. And the other thing that I want to tell you is that this is, I am not an expert. I'm a generalist. I'm a nurse practitioner with expertise in cardiology and cardiothoracic surgery. But I also work in general practice, and so I do a little bit of everything. Interestingly enough, all the things that I've shown you in today's presentation, I've actually seen in real life. And so hopefully I'll be able to share some of my experiences with you, but I am not an ENT specialist. So if you're expecting that, sorry about that. As far as today's presentation is concerned, I do have, this is going to be audience participation. All right, have you guys ever used Slido before? Raise your hands if you've used Slido before. Okay, get your phones out if you've got them. If you don't have one, sorry, you're not going to be able to participate. This was very, very last. I finished this presentation about 10 o'clock last night. So that's why you don't have copies of this presentation. And the reason why I finished it last night is because it was really hard, because I'm trying to actually complement other material that will become more relevant later on in this course. So you just go to slido.com. There'll be a little box that says enter your conference code, put in EAR, and that will get you into a little screen that looks a little bit like this, okay? And how this works is that during my presentation, if you have got questions, concerns, I love a good sort of, no, you're wrong. I love to have these discourses because we all learn from it. I am not the ultimate expert here. In fact, we as a group of nurses are the experts in this room. So go ahead and ask your questions. If you see a question that somebody else has asked, just like it, and it will bump that question up to the very top of the list. So if you see a question that you really want asked, like that question, and I will eventually answer that question later on. Also, it's not moderated. So if you notice that my fly is down during the presentation, perhaps don't mention it on that. Just sort of do a little, Chris, your fly is down. So just keep in mind that it's not a moderated conversation. Any questions about that? Was that? It should be up in the moment. Yep, you should see something that looks like that. Sure. Okay. If you've figured out how to do it, help your neighbor to get logged on if you can. And that will work quite well. All right. I'm actually going to just see, somebody put in test, whoever's on. Hey, there you are. So we've got one already that says good afternoon. All right. So just put your comments in there. You can put it in anonymously, or you can attach your name, your first or last name. Doesn't really matter to me. But there you go. It's working. All right. So I'm just going to go ahead and clear these. Okay. So here we get started. Okay. So going on to ear irrigation. Today we're going to be talking broadly about ear irrigation. It's not called ear syringing because that's actually a very specific type of irrigation. We're going to be talking about issues around clinical governance. There's a lot of you here today because you're like, I've heard that I need a certificate in order to demonstrate competency. And so I really wanted to come to this course for that certificate. We'll talk a little bit about that. We're going to be talking about an in-depth look into history and examination. Right now, my goal as a nurse is to actually help everybody develop their advanced practice. And so out of this presentation, hopefully you're going to get a lot of sort of differential diagnostic skills to actually help you identify. Sometimes it's not just cerumen. Actually, there's something else going on, and I want to talk to you guys a bit about that. We'll be talking about, oops, how to go backwards? There we go. Approaches to management as far as cerumen is concerned, or earwax is concerned. The actual procedure itself, we can't do that here. I hope to give you guys enough information, theoretical information, practical information, that you can go back to your workplaces and say, if you've never done ear syringing before, you can go to your employer or the medical practitioner or nurse that you're working with and say, hey, I'd like an OSCE on how to do an ear examination, and I'd like an OSCE on doing some ear syringing, and develop an education plan to help develop your ear syringing expertise, and then you're marked off and you can go, all right? You don't need to take any additional courses. So I also want to talk about red flags and when to refer, because that's simply something that's quite often forgotten when we talk about ear syringing or ear irrigation. We forget about those red flags and things that we need to be looking out for. So, why this course? Well, number one, there's been a lot of APNA member feedback asking for clarification about the expectations for ear syringing. Ear syringing is not something that you get in your Bachelor of Nursing program, all right? It's not something that you normally get in your nurse practitioner program. It's not something that anybody normally gets in their education. So it's really about saying, hey, it's a common problem. In fact, it's so common that when I was working at the Wolkin Center in the ACT, which is a nurse-led walking center, I am almost positive I can build a business just on ear syringing alone or ear irrigation alone. I mean, okay, how many times a week do you guys get ear irrigation? I get it at least 6 times a week, what I'm trying to tell you that when we're talking about, for example, nurse-led clinics, all right, well, I know of nurses that have built an entire business based off of Gumtree, off doing toenail clipping for diabetics. They just post their advertisement on Gumtree, and that's what they do, and they do very well at that. There's nurses that do a business with chronic disease management plans and for general practices. This is actually one viable opportunity where you can actually become the expert. So just think about how this could actually be used in your practice to actually generate professional satisfaction for yourself, but also income for the practice and yourself as well. So one of the things that we commonly hear about is, well, do I need to take the ear syringing course? Now, there is only one vocational educational and training program here in Australia that does ear syringing. It's called Ear Health or something like that. There's only one provider that provides that training. They are national, but this is not that course, okay? A lot of the things that I'm going to be teaching you today or talking about today align with that course, plus a couple additional things to give it a bit of oomph, okay? Particularly for an audience of registered nurses that have already gone through their education programs, and I want to provide additional training above the level of a Bachelor of Nursing or a graduate diploma as an enrolled nurse. So the purpose of this is to build upon your expertise. So with respects to the NMBA does not expect you guys to have a certificate. What they do expect you to do is seek further postgraduate education and training to help augment your skill base. And this is what this is doing, all right? You need to augment that with practical experience, and that's what you guys do when you go back to your individual workplaces. So, and ear syringing is literally, can be taught to anyone. It's the knowledge that informs that skill that's key to providing safe, effective, and efficient care for our clients. So you can train anyone this skill, but it's the knowledge informing it that really makes a difference, I feel. I will also say I can't speak for 4 hours about this. It's impossible, all right? And I'm certain that you guys would be thankful for that. So if we do get done early today, fantastic. Plenty of times for questions, but at the end of the day, I've never run this presentation before, so I could last 4 hours, but I hope not, okay? All right, moving on. Why is this important? Okay, first and foremost, from a litigation standpoint, we know that in general practice, and this is based off pretty old data actually, 1997, before nurses were really upskilling and doing this a lot more in general practice, but we know that about 19% of procedural claims done in general practice are accountable to ear syringing. So you think about the toenail wedge resections, you think about the implanon resections, or insertions, or the removals for that matter. You talk about all the different things that you see in general practice, and 19% of those claims are due to ear syringing. The vast majority of those claims have to do with poor technique, not knowing what you're doing. Yep?
Sorry, Chris, I just want to comment, because I did the otitis media course last year.
Yep.
And they're saying now 25%.
25.
Ear syringing makes up less than 1% of the procedures done in general practice, and yet it is 25% of the litigation.
Isn't that right? Is that because I was looking for more current literature? Is there?
I think so. Well, that was what I was told last year.
So that's the kind of information. So this is really old data based off of basically a cohort in Western Australia. Yeah.
I was just going to ask, Chris, with the litigation, do we know is it litigation against GPs or nurses? Who are the people that are the ones getting?
It's the GPs that are usually getting dinged, all right? But there's also some really interesting broader contextual things that are happening. So this data is from 1997. You know, our education and training here in Australia has changed dramatically around, actually later around that time, you know? So I would say that, for example, the NMBA has said, you as individual nurses, whether you're an enrolled nurse or a registered nurse, you are accountable for your individual practice. You can't just say, oh, you know, that's the GP's job. No, you're individual professionals. And so with respect to these claims, I'm actually going to be interested to see through time whether or not there's a shift away from the GPs to the nurses that are performing these procedures. And that's why I'm providing so much information today, as you'll see later on, about differential diagnosis. And yes, your nurses, you can diagnose this. You can't do a medical diagnosis, but you can do a diagnosis. There's a big difference between the two, all right? So using relatively old data, we know that most of the time the reason why somebody gets sued is because they've taken the device, they've gone in there, and they've either gone way too far and punctured the tympanic membrane with the irrigation device, or they've actually caused a hematoma inside the ear canal. And so from a poor technique standpoint, or for example, you know, they use freezing cold water in your ear during ear irrigation, and that is also a sign of poor technique. And ultimately, that poor technique is because you don't actually know what you're doing. So you're practicing outside your scope of practice. Faulty equipment is actually an interesting one. So the second most common are faulty equipment and excessive pressure. The faulty equipment has actually happened to me, but not in a terrible way, but I'll show you later on how faulty equipment can actually play into this. Faulty equipment could mean, geez, you didn't attach the nozzle and lock it into place, and it shot right into the ear canal. Faulty equipment could also mean that you haven't been actually cleansing your device, and there's a huge growth of Pseudomonas in that device, and it's caused a massive infection. So that's what faulty equipment encapsulates. And then finally, we've got excessive pressure, which is also the second most common reason, is that you're sitting there and you're like that into the ear, and you're causing a traumatic rupture of the tympanic membrane. And finally, only 5% of these claims are because nobody bothered to actually look in the ear. Like there was no examination whatsoever. They just started squirting water in there. And so I guess the good news to you guys is that that's not a scope of practice thing. That's just a negligence. That's just bad practice. I mean, you know, and stupidity. Yes, thank you very much. So I guess when we talk about complications, we talk about the most common are you just can't get the wax out. And that's not a major complication, but it's something that has implications when people have physical deformities and you actually worsen the condition by irrigating. So failure to remove is a common complication. It's not life-threatening usually. It just causes more bother for the patient. Otitis externa, or an infection of the ear canal, perforation of the eardrum, and damage to the canal, pain, vertigo, otitis media. It's really, really important. You guys are autonomous health practitioners. You guys do work in collaboration with other health professionals, but when you're providing a procedure, you're doing the procedure. It's not the GP's job to actually provide the risks, benefits, and alternatives. It's your job as a person who's providing the actual procedure. That's my opinion. I'm sure that some of my medical colleagues might differ on that opinion. Some of my nursing colleagues might differ on that opinion, but we are in the day and age where the doctor told me to do it no longer flies. You are accountable and responsible for your own scope of practice. So if you perform a procedure and you have a differing opinion of whether it should be done, it's actually more on you these days. And that's what the legal cases are actually showing that I work with as far as an expert witness. So when you talk about the risks, benefits, and alternatives with your client, you should mention that a minor complication occurs in 1 out of 1,000 cases of ear syringing, which actually frightens the crap out of me because I'm definitely over my 1,000 cases of ear syringing. So pretty soon, I'm going to cause harm. And that's just not because I'm being careless. That's just the odds game, folks. So when we talk about minor complications, we talk about a burst eardrum. We talk about perhaps a laceration where you use a device such as an ear syringe that's metal and it's got, the tip is not filed correctly and it actually causes a laceration. Infections and hearing loss, all these things can happen about 1 in 1,000 cases. Major complications, actually we don't actually have really good data about major complications. I'm going to show you what major is, but 1 in 10,000 to 1 in 100,000 is when we talk about the oh crap. Ear irrigation has resulted in death, and that can actually happen. I know, I was completely shocked when I figured that out myself. But the thing that you fear, the one thing that you really get scared about as a result of ear irrigation is malignant otitis, external otitis. Now, I'm sorry that you guys have just eaten, but there's going to be more. So, malignant external otitis. So really bad infection of the external ear. You really have a high risk with diabetics, particularly diabetics that are not well controlled. So we're talking about hemoglobin A1Cs of 8 or above. You really start increasing your risk for malignant external otitis. People that are actively immunocompromised. So that includes people that have an active diagnosis of cancer and are actively taking immunomodulators, things for their actual their chemotherapy. We're not talking about people that are HIV positive. People that are HIV positive, they could have completely normal CD4 counts in their bodies, and they're well controlled. Their viral loads are less than 50. These people, just because you have HIV doesn't mean necessarily that you're immunocompromised. And if you're unsure of whether somebody is immunocompromised, you need to get a second opinion. And that's where your colleagues come into play here, your general practitioners, your fellow nurses, et cetera. And the research has shown that you're much more likely to get malignant external otitis as a result of ear irrigation if you're greater than age 60. So just some things to consider. And there's some things that you can do to mitigate that risk. And I'll talk about that later on. As far as signs and symptoms, this is where the education, the educative piece really comes in and is really important for you guys when you do some ear syringing. It's not just swish, you're gone, out you go. We're nurses. We sit there and we educate our patients and we talk about, gosh, how can you actually help prevent this from recurring again? We talk about, for example, what you should do, what you should look out for after we do this ear syringing, all right, or ear irrigation. And it's really critical that you talk to your patients about, listen, if you get any pain, discharge, swelling, anything at all that's going wrong with your ear within a couple days to up to a week after this process, you come back in and we have a look at it. In 100% of these cases of malignant otitis externa that happens quite quickly, that is life-threatening, it can actually migrate into the bone of the temporal bones, the occipital bone. It can actually migrate and cause thromboses inside the brain and abscesses inside the brain and kill you. And there are actually documented cases of death from this condition, and it moves relatively fast. You know, we're not talking fast, but you know, we're talking about maybe 1 to 2 months before it really, the crap really starts hitting the fan. So I suppose if they come in with any sort of pain or swelling or a fever, make sure that is immediately viewed by your collaborating general practitioner, nurse practitioner, or what have you. One of the things that we don't really talk a lot about we always talk about cellulitis, but one of the things that I didn't know, that there's a subtle difference between cellulitis and erysipelas. Erysipelas, I should say. And I just wanted to show you what erysipelas means. It's basically this sort of, can you almost sense that the skin is almost like an orange peel? It actually starts getting a little bit more inflamed than a typical cellulitis. It goes down into the superficial cutaneous lymphatics, and so that's why you get that sort of puffiness to that area. And that stuff is always very, very difficult to actually control. It's actually quite painful. And by the way, if you are into skin, like I am, I love skin, and you really want a great education piece with lots of great nasty photos, go to dermnetnz.org, I think it is. Isn't that right? Anyone know? Yeah? Great. New Zealand has some really fantastic resources, particularly out around dermatology, and this is where I received this image. So what? So at the end of the day, we know that there are actually very few clinicians out there that cause harm just because they're idiots, all right? That they actually didn't even bother looking inside the ear. They didn't bother providing a really holistic assessment of somebody before they provided syringing. Most cases are due to issues around clinical governance, and we'll talk about clinical governance later on, and individuals actually practicing outside their scope. Oh, that looks pretty easy. I'll just go ahead and do it because it's just a little bit of water in the ear, and it's actually a lot more than that. So this presentation is really about clinical governance. You guys are going to be all asleep, I suppose, by the end of this presentation, but I actually kind of want to get you guys excited about clinical governance because it's something that is relatively new even to me, and I'll tell you a little bit more about that later on. But this is about increasing your scope of practice through education and then having a practical component that you decide with your supervising practitioner or the person who's actually going to be signing you off on in the local context. Your scope of practice, I'll be talking a bit about this tomorrow, about scope of practice, but at the end of the day, scope of practice is about knowledge, skills, and experiences that give you ability, and the ability to do something safely and effectively, okay? There's lots and lots of layers that help determine your scope of practice. You've got professional standards, for example. You've got jurisdictional law and regulation around practice. You've got organizational policies that either facilitate or restrict your scope of practice. And you also have your individual scope of practice. So your individual scope of practice is quite different from the professional scope of practice. And we'll talk about that more tomorrow. But at the end of the day, this is just filling one requirement of expanding your scope of practice if you've never done this before. This little quote right here is from the NMBA, and it specifically relates to nurse practitioners. They have a little statement on the NMBA website about how if a nurse practitioner wants to change or expand their scope of practice, this is what the expectation is. Well, guess what? That's not just the expectation for nurse practitioners, it's for everybody. And the fact that we don't want, if you decide as a registered nurse that you want to start providing antenatal care, all right, to clients, which is actually delving into midwifery, which is, again, bringing us some professional issues. There would be an expectation that you actually take a midwifery course to actually then start providing antenatal care from the perspective of the wellness of the woman and the baby. I think that when you talk about what the expectation is, it's about saying, okay, what do we get during our normal bachelor's programs? And how do I then expand upon that scope of practice? And reading textbooks from your Bachelor of Nursing course isn't helpful. You need to be reading things material, for example, journal articles, magazines that are for the person that has already graduated, that is actually in practice. That's the kind of postgraduate education that we're talking about. So when we talk about clinical governance, I actually didn't know what clinical governance was when I stepped into my role on the NMBA. I probably shouldn't admit that in a public forum, but there you go. So clinical governance is not something that we talk about in patient care. But the more that I learn about clinical governance and about operational governance and governance full stop, the more I'm like, this is everything that nursing is about. We're about public safety. We're about transparency. But it's about knowing how to do your job, but it's also about making sure that you're doing your job well. That's what governance is. So it describes a systematic approach to maintaining and improving the quality of patient care within a clinical care setting, health program, or health system. It's at the end of the day, from a clinical governance perspective, we talk about clinical governance for the protection of the patient. We talk about clinical governance to ensure that we have processes in the local workplace that make sure that our colleagues are actually current, For example, when you sign off every year for your annual registration for your nursing registration, you tick a little box that says, yes, I've conducted my CPD. That's actually part of a governance program to make sure that you're attesting, you're providing a stat deck that says, yeah, actually, I've been doing my CPD and I'm maintaining relevancy to not only my profession, but most importantly, relevancy to my patients using the best evidence-based approach. And so I would challenge you to think about clinical governance more in your workplaces. And recall and reminder systems is a prime example of having good clinical governance in your organization, making sure that you've got that nailed down. That's good clinical governance. When we talk about clinical governance, we talk about policies and procedures. They go hand in hand, all right? There should be policies in your workplaces for ear syringing or ear irrigation, depending on the devices that you're using. And it should talk about the parameters for practice. For example, can you do ear irrigation in a 6-month-old? Should you be doing that? That's what these procedures should be outlining. They should be talking about, for example, what in specific situations where we have somebody who's immunocompromised, who has, for example, rheumatoid arthritis and is receiving immunomodulators to help control their symptoms, how do we approach that patient versus another patient so that they don't get malignant otitis externa? We make sure that we have a process about documentation. Who here uses, who's done ear syringing before? Ah, lovely. So, and who here uses electronic medical record system, not paper and pen, like best practice medical director? Most people, all right? I'm a massive fan of using some of the inherent tools in these EMRs, like best practice, to use autofill templates to help kind of guide your documentation, because it makes your documentation consistent. And that is always a beneficial thing from a governance perspective. So maybe perhaps in your policies and procedures saying, this is what we would expect to have in our documentation. And finally, talking about regular review of care, making sure that you're actually reviewing your ear syringing or ear irrigation on a regular basis by looking at case review and looking at in those cases where there's been an issue, how that care has been escalated. So effective clinical governance is not this sort of onerous process. It should not be onerous. And in fact, very soon, APNA will be coming out with a course for ear syringing or ear irrigation that's going to complement the information that I'm providing. They actually provided me early access to their ear irrigation course, and I've worked very hard to complement the information that they've provided, and some of it's been duplicated because, for example, with clinical governance, I think it's so important, and it should be important in your individual practices as well. But at the end of the day, your policies and procedures don't need to be pages long. They can be 1 page. They can be 2 pages. But really, it's about, is your clinical governance of your organization protecting the public? Is it transparent? So if somebody says, what's your process for signing somebody off on providing independent ear syringing, you can say, yeah, it's right here. That's our process. They need to have these qualifications or these experiences to, or for example, OSCEs, for example, to actually demonstrate competency. That's one thing you can consider. It's flexible.
What's that? Sorry, what are you saying, OSCE?
OSCEs, objective structured clinical examinations. It's basically saying, hey, I want you to demonstrate how to use an otoscope. And on my little piece of paper, I'll have things that you absolutely have to do, and then optional things that, hey, are just the icing on the cake. So it's basically saying, objectively, you've gotten the essentials down, and with an OSCE, you can also show off and do additional things to show your level of expertise. It's a little one-page piece of paper. All right, so it's flexible because, actually, just because you're a general practitioner or a nurse practitioner doesn't mean you should be doing this. Just letting you know that, just because you've got a title doesn't automatically make you competent to actually be doing this procedure. And I hope that the reasons for that become quite evident later on. So I would say even general practitioners should be actually adhering to this clinical governance framework, saying that they too are doing it safely. Because let's face it, general practice is this huge, there's so much you need to know in general practice. And this is just one tiny piece, and sometimes you may not have the knowledge or expertise to be doing what you're doing. It encapsulates best practice and reflects and refines, and so there's mechanisms for review later on, all right? Documentation, I can't tell you how many times that documentation has saved myself professionally, but it's also been quite helpful in some of these medical legal cases that I've been working with. It's, unfortunately, we're going towards the way that the US is as far as litigation is concerned. Cover yourselves. You need to make sure that you use those autofill templates that are built into the EMRs to cover yourself and make sure that you're actually documenting the good work that you're doing. Because 90% of the time when there's something has gone awry in a case, it's because the nurse actually says, no, I did that. Well, not according to the record, you didn't. So you need to make sure that at the very bare minimum, you're documenting this stuff right here about why. Just because you've got earwax doesn't mean that you should be getting ear irrigation. Talking about an assessment for red flags or contraindications or cautions. Talking about, for example, during the irrigation, did it come out bloody? Did it come out smelly? Did it come out, did a large chunk come out? I do love it when that big chunk comes out. I don't know about you guys, but I just, yes! I really love that. And most importantly is the pre and post observation of the tympanic membrane as well as the ear canal itself. And any symptoms, of course, reported during or shortly after the irrigation.
What would be the difference between irrigation characteristics and cerumen?
Yeah? Okay, so irrigation characteristics could be, irrigation characteristics, so I had to use 2 liters in one ear. All right, and when I did a flush, there was blood, for example. The actual cerumen quality and character, like sometimes, how like when you irrigate, you just get little flecks? Yeah, that's in, we'll talk about that a little bit later on, but those little flecks are usually, you look back in there and it's still there, and so eventually those flecks give way to this massive plug if there's a sufficient plug in there. So that's the stuff that I'm talking about. Does that make sense? Yep. Okay, time for a small break.
Sorry, would you, with the irrigation, what was there, would you also put the equipment that you've used?
That's generally covered already in your policy and procedure. So, the type of syringing device that you're using and its maintenance is really, important to have in that clinical governance framework that we're talking about. Absolutely. Yep.
Also, Chris, with the latest 5th edition RACGP standard,
Yep.
you now have to prove that your staff have had training.
Oh, do you?
Yes.
Ah, fantastic.
In fact, not just on syringes, on everything.
Yeah, good.
It's a requirement to prove.
That's brilliant. That's good to know. All right. So it would be actually quite interesting to see if the RACGP then starts developing resources to help facilitate general practices, because you know how they do that on the back end of their website. They have.
Well, they're saying there's no, as long as you've got proof that you've had training in that, because one of the high risk areas is faulty equipment.
Yep.
So even though you've had the maintenance done every year, and the nurse is accountable to check that at the time, if they haven't been trained properly, you're responsible.
Yep. Yep.
So does this disqualify what the training is?
No.
It's a very, very loose statement of training, and it could be that you read the manual and watched the YouTube video, the other nurses trained you, as long as you're, as their user, confident that you've had training and you're confident you did it.
Okay. So yeah, I think that one of the things that I commonly hear about is, should we be regulating, for example, specialty areas, and should we also be providing mandatory training? be careful what you ask for as far as mandatory training. Do you really, really want to put more barriers to your care for the benefit of your patients, as opposed to taking accountability for your professional practice and just saying, actually, I don't know enough about this. I'm going to do more research into this area. I'm going to get some more practical experience in this area. But mandating an actual course for ear irrigation, I think, is probably the worst thing that we could do for ourselves professionally. But saying, hey, if you want to take an ear irrigation course just because you want to actually expand your knowledge in that area, that's completely different. But mandating it for your scope is actually quite problematic. We've got some questions about, please advise on the benefits of ear syringe versus suctioning in terms of risk and benefit. That's coming later on, Jenny, so thank you very much for asking. But yeah, that's going to definitely be addressed later on in at least some sense later on in my presentation. So that's that. What other questions do you guys have? Should we not be syringing those with diabetes due to malignancy? No, I think that having a risk. Sorry, I'm just get rid of this one here. Having a discussion with the clients about the risks and benefits is really important. Talking to them about, these are the risks, and this is how I'm going to mitigate that risk. This is how I'm going to help prevent this from happening. And in addition, if you've got a complete ear occlusion and you can't hear, and excuse me, even if you're quite honestly, imagine the case, and this has, to my knowledge, happened where you've got somebody that's being palliated. They've got 6 months to live, and they've got a complete ear cerumen blockage, and it's because they have an active case of cancer, and they're getting palliative chemo as opposed to therapeutic chemo. So everything that I've told you says you shouldn't be irrigating that patient. But after having an informed discussion with that patient about, this is the risks and benefits, but the patient says, I can't actually hear my relatives talking to me, what are you going to do? So you do talk about the risk, and this is how I'm going to mitigate the risks. Is that acceptable to you? And then you document that conversation, all right? It's, unfortunately, when you get into more advanced practice, when we first got out of nursing school, remember how comfortably we sat in black and white issues? It was just so nice to have a black and white answer to everything. But as we've all grown into our roles as nurses, we realized that healthcare is not about black and white, and we would love it to be about black and white. But there's a hell of a lot of gray out there. And ultimately, how you get past that gray is having an informed conversation with a client and then documenting that. Syringing children, age limits. We'll talk about that later on. Good question. But I personally have syringed down to the age of 2. The biggest problem that you really encounter with children is compliance. They're squirming all over the place, and the last thing you want them to do is do one of those and perforate their tympanic membrane. I personally think that you have to be very careful with children, particularly when you're talking about ear syringing and ear complaints. If they're tugging at their ear, there might be something else going on inside their ear, like an otitis media. So when you start going into children who are prone to recurrent ear infections, you really need to be thinking about your holistic assessment of the patient and making sure that this isn't just cerumen, that there's something else going on. Does that make sense? Yep. Eardrops, we'll get to that. Yep, we'll get to that. Sounds like we'll keep on going here. Okay. Was that, by the way, was that process straightforward for everybody? Yeah? Okay, good. All right, so we're going to archive all those. Okay, we'll start over. Now, moving on. So developing your scope of practice, anatomy and physiology. So knowing that I had the after lunch, you're falling asleep, I apologize for this. We're going to go through some basic anatomy and then start going into enough anatomy and physiology to get you through. I guess, this is the point. I always have a couple sort of presentations where people start talking about external characteristics. So in other words, the phenotype. Ears are quite fascinating. You can tell a lot about a person by their ears, actually. But with respects to my ears are, never mind. So overall, excuse me, I had an atypical pneumonia 3 weeks ago, and I'm still coughing. I'm not infectious, but if I cough, I'll try to cover up my microphone, okay? I'm not infectious. All right, so the tragus is one of my most favorite parts of the ear anatomy because that's where I provide a lot of advice about instilling eardrops as far as getting those eardrops really into the ear. I always talk to people about inserting those eardrops and then massaging the tragus for a good 20 seconds to really push those suckers in there, that medicine in there. As I said, as part of your assessment, as part of your holistic assessment of this client, you really should be doing an assessment of the ear. And I'm going to show you some interesting things with the ear later on that shows the import of doing that and making sure that if you do identify abnormal findings on your ear examination that you escalate those. And ears, there's lots of interesting ear issues that can occur. There's severe deformities of the ear that are congenital, but at the end of the day, you don't have to have a severely deformed congenital of the ear to actually identify another major significant health issue going on. Common variants. When you see these things, it's not a big deal. Okay, this one right here. In fact, I think it's 1 in 5 people have these Darwin tubercles. All right, I think I've got one. This is not, a remnant from getting your ears your ear pierced back in the 80s. It's not that remnant. It's actually a remnant from our ancestors, the chimpanzees, the apes. So it's benign. It's not something you worry about. It's a fleshy growth. And if you do see something about that, it's not a big deal. Duplication of lobule. How many of you guys have seen something like this little weird tag that can be somewhere on the entire ear, but it's most commonly located right here behind the, has everybody ever seen that before? That's actually just another part of, from fetal development and is actually completely normal. It may be cosmetically unappealing. So this is a pre-auricular tubercle right here, and these are the ones that are usually taken away quite early on in childhood because they are so cosmetically disfiguring but they're harmless, So these are normal, common variants that you'll see in clinical practice. Just a brief note about prominent ears. Something that I also didn't know when I was actually doing this presentation was that when you've got, little, in the United States we call them bat ears. It's very offensive, particularly for the mothers. But we got these ears, and I didn't know this, but if you can actually splint those suckers before the age of 12 months, certainly, usually ideally around 6 months, you can actually avoid ear surgery. Did not know that. So I actually did a bit of research on this area, and it's because the cartilage actually hasn't solidified the matrix, the cartilaginous matrix. And so you just basically put this little splint in and put it back, and after about 3 months or so, it will actually solidify, particularly after the period. That's when the matrix really solidifies. So that's something that in our well child checks, in our baby checks, that's something that we could look out for and actually potentially mitigate for later on in life for this kid. Otherwise, you really want to consider about getting this corrected if you're concerned about it before the ages of 4 to 6, before they get actually into school. Where they can be teased.
Would you send them to get that?
I would just send them to the ENT specialist. Yeah, I would send them to an ENT specialist. I'm sure it's actually, once it's actually, the actual mold has been made, it's actually quite, yeah.
How long do they stay there?
Until after the matrix solidifies. So it stays on for a bit, yeah. Yeah. Interesting. Who knew that? See? Okay, you knew that. Right. Fantastic. Do you have any other additional information about that? No? Okay. I've seen these also in practice commonly. Pre-auricular sinus is this little dimple right here. And the reason why those are important is because they are prone to getting staph infections and turning into first this, and then getting a full-on necrosis of the skin as well. I haven't seen that bad. I was going to put in the surgical correction for that. That's pretty nasty, but I'm not going to do that to you guys today. So at the end of the day, pre-auricular sinuses in themselves you don't need surgery on them, but I would say that from what I've seen from the literature, if you're getting 2 to 3 infections per year in that area, they really need to be sent to an ENT physician for removal of the sinus so that they don't get recurrent infections. Okay? But again, these are things that you don't have to say to your patient, oh, you've got a sinus, we need to send you to an ENT doctor. No, just wait and watch, because not all of these get infected like this, all right? Okay, quiz time. Wake up. So, what is this? What do you think that is?
Keloid.
Correct. Fantastic. So keloids is this little girl actually had her ears pierced and then developed a reactive scar tissue that basically outgrew the margins of the actual piercing hole. And this is what a typical keloid is called, or looks like, I should say, for a pierced ear. You can do intralesional corticosteroids for those things. You can actually put steroids like Solucortef into that actual area. That's a bad example. Some sort of steroid, the white stuff, what's it called? Anyone? Depo? Yeah. The white stuff into that area, and that, I don't do that. That would be a dermatologist thing, or no, a dermatologist thing. But that will actually quite frequently, not frequently, but that has a chance of resolving those keloids if you catch them early enough. What's this next one right here? What do you guys reckon about this? Is that? Correct. That's a melanoma. So really making sure that when you're looking at your ears, you're looking out for things like melanoma or a basal cell carcinoma. How many of our patients have we seen this on and just said, oh, they're just old, that's, but that's the kind of the ageism that we see within practices. We see that's just normal. Actually, no, this is actually either a precursor, actinic keratosis, or it's a squamous cell carcinoma, or it's a basal cell carcinoma. And that's something that can be actually rectified. It's not, either with, in some cases, medicines, topical medicines, or with minor surgery. So yeah. Moving on, you will see a lot of crap there on the internet. This is one of my favorites right here. There's a website which, full disclosure, I'm a big believer in acupuncture. I don't think you can actually go wrong with 5,000 years of evidence. But on this website, they were actually showing the pre and post images of, for example, conditions where they had hemorrhoids or rheumatic heart disease. And they can say, they were actually saying this. I double checked this on the website. It wasn't saying, this is where you insert the needle. It was saying, this is a sign of rheumatic heart disease. So there's a lot of crap out there. But there is some interesting stuff out there that does have positive correlations or associations. That's actually quite fascinating. Who can tell me what this little sucker is?
It just looks like a little SCC to me.
Yeah, it looks like an SCC. It's firm. I'll tell you that. It's firm. It's like a little nodular almost. Any guesses? Who's heard of gout or gouty tophi? Excuse me.
Really?
Yep. Gouty tophi can occur anywhere in the body, mostly over the extensor surfaces of your elbows, your knees, for example, but they can occur anywhere, and that's also a very common sign for really poorly controlled gout. All right, next one. What is this a sign of? Correct. Good. There's an association. Now, this is the part where people start going, and looking at their neighbor and looking, feeling from themselves. It doesn't mean you have it. It just means that there's an association with obstructive coronary artery disease. And it is commonly seen with age. I used to think that that was actually associated with using an earring, but it's actually not. The gentlemen that we work with usually have not had earrings in that ear or those ears. It's usually bilateral as well.
Is that male and female?
Yeah, male and female, absolutely. Next one. This is my favorite one because I've actually seen this in clinical practice. So how would you guys describe these lesions? They're flat. I'll tell you that they're flat. How would you describe those lesions? Okay, fantastic, because they are blue. They are blue. They've got a bluish tinge to it, and you actually, that's exactly what I thought as well. All right, so those are, first of all, they're macules, so they're flat, all right, and they're well circumscribed, and they are scattered over the ears. They're also homogeneous in color. They have a bluish tinge to them. Those are called blue nevi, all right? Blue nevi in themselves, we will invariably, by the age of 90, get a blue nevus on our body someplace, okay? Some people are more prone to them than others. But this, when it's actually prolific, is a sign of Carney syndrome, which is something that I've actually seen in clinical practice. I saw it from my background in cardiothoracic surgery, where you can get tumors miscellaneously through your body. I saw a tumor that was actually an atrial myxoma that was huge on the echocardiogram, and he had to undergo surgery for that condition. The point being is that this is more than just ear irrigation. This is more than earwax. This is part of your knowledge and skills to say, I'm actually a really informed practitioner. I'm going to look at this ear, and it starts with looking at the pinnae, all right? We talk frequently about the external, the middle, and the inner ear. The inner ear is where all the nerves and the bones that we get concerned about are. We talk about the middle ear, where we talk about middle ear effusions or otitis media. When we talk about otitis externa, we talk about the external ear. But basically, when we talk about earwax, well, this is where the magic happens. Earwax doesn't start from right here. It starts right here with the apocrine glands there in the ear, which is where you'll find some terminal hairs and cilia as well to help push out that earwax. So that's where the basis for your nurse-led clinic starts, right there. And I'm dead serious. Think about doing a private ear irrigation clinic. Anyway, when we talk about the inner ear, I'm not going to bore you with lots of Latin names. I'm not going to bore you with irrelevant anatomy that hopefully you'll never ever be seeing, the tensor tympani muscle, for example. The reason why I've highlighted those is that I think it's quite fascinating that these tiny little muscles are responsible for major symptoms. Have you guys ever heard of middle ear myoclonus before? Have you ever had a patient that comes in and says, I'm getting this really weird sound in my ear, and it goes da 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 da? Nothing like that? No, it's just me. Okay. Yeah. So you, okay, all right. So who here has actually just been sitting there calmly, and the muscle in your arm starts just twitching madly by itself? No one? Yeah. Come on, all right. Okay, all right. Same situation is that you, particularly with people that have a great deal of stress, anxiety disorders, they can actually, there's lots of reasons, even viral infections can cause this middle ear myoclonus, and it can actually be debilitating, where you basically get a twitching of the tensor tympani muscle, or you get a twitching of the stapedius muscle, and it's a bup, 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 bup. You know, imagine if I was, you know, here you go. That's what's happening inside your ear. It's driving you mad, okay? Whoops, sorry. So middle ear myoclonus. So when you talk to your patients before you start syringing, you're talking to them, any strange sounds, any ringing in your ears, any pressure, any fullness, any sort of, any sort of abnormal sounds that you're experiencing, just because you want to look at maybe you've done the ear syringing and they're still having the symptoms. Maybe it's because they're having a myoclonus of the muscles. The fascinating thing about the tympanic membrane is that this is a type of dye that was used on a cadaver. And the point of it is that they've actually done studies, and there's actually in vivo studies with using live patients, where they've placed a little ink dot right there on the tympanic membrane of the eardrum. And through the course of time, it actually works itself out towards the exit of the orifice of the ear. It's assisted by earwax. It's also assisted by chewing and talking. So I'm just spitting out ink blocks out of my ear really quickly. But the interesting thing about the tympanic membrane is that it does not disclammate. So our skin disclammates. We have, we get dry skin and it starts peeling off. The eardrum doesn't normally do that. It actually moves it along down the canal like a little conveyor belt. And that's actually a part of the process that helps get rid of earwax naturally, okay? So that issue of disclammation, so again, your tympanic membrane doesn't normally shed like our skin does. It is like a conveyor belt and goes from the tympanic membrane, the umbo area, and just goes on out through the ear. So now we're going to start getting into the actual, we've looked at the pinnae, we've looked at some of the ideas behind the physiology and anatomy, and I just want to back up just a little bit here, sorry. I do want to really highlight the fact that look how thin, it's millimeters, that skin is before it hits the periosteum of the temporal bone, all right? So it's really, really thin in that area. So you need to consider that when you're putting, for example, some hot water in there, or you're putting some cold water in there, or if you're simply, you've put the probe in too far and you've nicked the skin, you're actually nicking it really close to the bone. And that's how things like osteomyelitis occur or bone infections occur. So it's a very highly sensitive area. Just be aware of that. Moving on to the actual examination equipment. I've used both of these devices. Do you guys have any other sort of devices in your, this is the Welsh Allen, this is the Heine. Does anybody else use any other devices? Just these two? They're common. I have this one right here. I like this one personally for my ear examinations because it's small. It's about yay big. It fits my pocket. I can go everywhere with it, even go out in the community and have it in my pocket and just whip it out and basically look at ears if I want to, if I'm doing a ear screening, for example, in the community. So this is a great little device, cheap as chips compared to this device. If you have one of these devices, lucky you, because this device has a better magnifying glass on it. And this little knob right here helps adjust the actual magnifying glass for your refraction. So basically adjust for your vision. So you take your glasses off, put it up there, and you can use that little dial to help adjust the blurriness or the sharpness according to your own vision. It's a nicer, in my opinion, a nicer device, but isn't as flexible as far as removing foreign bodies as this device is. You have two types of specula that are commonly used with both devices, a small and a large. Obviously with a small, used with pediatrics or with patients with really narrow ear canals, and the large definitely goes with adults. And this is the one key part of your equipment regimen that you need to have in your offices. If your GP or your practice manager says, we're doing an order for equipment, do you need anything? And you'll say, yes, I need a pulse oximeter because it walked off with the last GP last week, or yes, I need a thermometer. You should be asking for an insufflation tube and making sure that your existing devices have you can't tell in this picture, but a little attachment to put that insufflation tube. This is the most widely underutilized tool in general practice, and it's extremely important for the use of diagnosing otitis media with effusion or glue ear. It's particularly important. I work with a lot of Aboriginal and Torres Strait Islander children, and sometimes you just can't tell what's going on in that ear. It looks normal, but something's going on with the kid. They're actually getting, they're not doing well in school. They're not listening to their parents. They're acting up, and it's actually because they have an undiagnosed otitis media with effusion that's not been diagnosed. And the only way you can diagnose it is with this little thing right here. So what it does is it attaches to the otoscope, and you put the little speculum on, and then you create a little seal so that there's no air escaping outside on either side of that speculum. And you create a seal, and you basically squeeze a little bulb once, and what you're looking for is for the tympanic membrane to move freely back and forth. All right? That's what it's used for. Who here has those in their office? Nobody. 1, 2, 3. Out of a group of 60 people, 3 people. It's really important. And it's just because I think that we, and I'm talking about all health practitioners, have underestimated its value. And it really is important. Right. So very difficult to do an examination in front of you guys. So I'm going to bring up something from Monash University on how to do a really proper ear examination with a otoscope, okay?
We'll start the examination of the outer ear by exposing the whole ear, about putting inside the hair, and just looking for any signs of inflammation, and also particularly at the back, checking the mastoid.
Mastoid bone, part of the normal part of the examination. When you're doing that ear examination, you're pulling on the pinnae, you're pushing on the tragus, and you're palpating like this around that area. Because a mastoiditis or an infection of that mastoid bone is not what you want, and in my book, is an emergency. Moving on, sorry.
And I often ask the patients, very gently, if I move their ear, whether it hurts. So, man, move your outer ear gently. Because if they've got an ataxic sternum, that would be very uncomfortable. And what I do is this, just gently pull up and back. Is that okay, Angie?
That's it.
I actually want to also say that you need to be doing not only this to look for an infection of a potential infection of the ear canal. This will be but if you do this, if you press on the tragus, right, and they have an otitis media, an active acute otitis media, that hurts a lot more, okay? So that's part of my normal examination, and I would recommend that you guys think about tugging, just gently, and then pressing. Warn the patient that before you're gonna do that, because sometimes you get a sort of a startled reaction where you're like, all right, I'm gonna be doing this examination, and you pull it, and they're like, you know, and were you in pain? No, I was just startled. So just make sure that you warn them. I'm just gonna tug gently on your ear, and I'm also just gonna push right here on this bit right here, okay? And I go ahead and push, all right?
Pull up and back. Is that okay, Angie?
That's it.
This is a typical otoscope with a speculum that has a small bevel that rotates on to make sure it doesn't fall off. You turn it on, and it's important to realise that this is for holding batteries. This is not for grasping the instrument. The best way is a two fingers and thumb approach from underneath, which is a very delicate way to hold this instrument. It frees up your little finger, which can then be placed against the cheek, especially of a child who may move suddenly. And if that was to happen, you move with them.
Really important. I think that's probably, and it's interesting.
Very gently.
Sorry.
As before.
The number of videos that you see on the internet, even some of the nurse practitioner videos I've been using for my education program at Curtin, that's not an endorsement, but I'm just saying that even the nurse practitioners are using it incorrectly. I really would like you guys to actually use this technique to help kind of reduce the risk of, especially with kids, of them actually causing damage to themselves. Very important. Don't worry.
That's it.
This is a typical otoscope with a speculum that has a small bevel that rotates on to make sure it doesn't fall off. You turn it on, and it's important to realise that this is for holding the batteries. This is not for grasping the instrument. The best way is a two fingers and thumb approach from underneath, which is a very delicate way to hold this instrument. It frees up your little finger, which can then be placed against the cheek, especially of a child who may move suddenly. And if that was to happen, you move with them. So, very gently, as before, we've checked that the ear is not tender, and in an adult, it's helpful to straighten the ear canal by gently pulling the pin up and back like this.
With a kid, you just pull straight back.
And indeed, children rather resent that and start reacting rather adversely if you do that. And they have quite straight canals, but in an adult, it can be very helpful to straighten the canal. Then very, very gently, looking at what you're doing, not looking through the lens at this point, you place the end of the speculum as far as you can see without hurting the patient. You don't want to ram it up against their external canal. And that's as far as I can see, obviously. And now you look through the lens, and you will often find initially that you're looking directly at the skin of the external canal. And then you have to very gently move it, so usually towards the nose or the forehead of the patient, usually anteriorly, before the tympanic membrane comes into view. And you will only see part of the tympanic membrane at this point. It's important then to be moved gently, move up, move to the slightly posteriorly and further up. And you are looking initially for the light reflex. That's a very good place to orientate yourself for the light reflex, to make sure it's normal, to make sure that the tympanic membrane is a nice pinky grey colour, it's glistening, and then keep going, looking all the way in the pars plasider and in the attic region. And then, having finished, just gently coming out. So now to examine Yoroshi's right ear, we change hands. So you hold the instrument in the left hand for the left ear and the right hand for the right ear. Again, gently extend and pull back the pinna. Gently place the tip of the speculum in the external canal, and then look down the lens before you can move it slightly to gain a good view of the tympanic membrane.
All right, so I think that one of the most common things that I see that goes wrong during a examination with an otoscope is that you really want to, you never take the otoscope and go in. You place it just in the entrance of the ear canal. That's what I do anyway. And the next thing you do is you bring your eye down into the otoscope and you take a look, all right? The thing that goes wrong is that when people come down to have a look, what happens? They push in. So just be conscious, because that skin is actually quite sensitive. I personally hate to have my ears examined. All right, so you're going to see those terminal hairs right there when you initially go in, particularly in older persons. And again, that's part of the apocrine gland network that produces the cerumen and the cilia that actually push things forward throughout into the orifice of the ear. And you get to this point and you're getting kind of chicken, and you're like, oh, should I go any farther? And most people will get to about this point, and you won't see the images that are going to be coming up in the rest of this presentation. You're not going to see those images, because those images use a special little microscope, fiber optic microscope. So this is what most of us see in clinical practice. And so that's why it's kind of nice to have that more expensive Welsh Allen. I'm not spruiking for them, but it's nice to have that Welsh Allen because you get a better magnified view of the tympanic membrane. And I have noticed that the lighting is a bit better with the Welsh Allen versus the Heine, all right? But you can go about that far and really get a good visualization. And just say to the client, just say, listen, I'm going to get a good view of the ear. It's going to be, it may be uncomfortable, but at no point should you experience any pain or discomfort. You know, so just let me know. But usually you can get about to the third one before people start getting a little bit wormy on you. Okay. So when he was quite right is that the first thing I always look for is that cone of light. That cone of light should be nice and crisp, and it should be nice and angled like this. You will sometimes see, and pay attention to that cone of light. It's such an important subtle clue as to what's going on behind the tympanic membrane, because in some conditions, that cone of light, which you'll see later on, is diffuse and spread out. You know, where's the cone of light? And it's because there's an inner ear issue going on. So pay very close attention to the cone of light. The cone of light reflects towards the nose. So just think that this is the anterior. So I'm literally right here, okay? And looking forward. This is how it's going to look when you look into my ear. If you're getting that close, which I don't want you to get that close. But you're in pretty far, and it should be pointing towards the nose. This is the anterior and the posterior of the ear, all right? It is important to kind of know how this should look so that when you see perforations, for example, you can identify, well, there's a perforation in the posterior area, in the attic area, things like that. So really coming to grips with the fact that right here in the middle was where the malleus connects to the tympanic membrane. That's called the umbo. And then you've got the handle of malleus, which you should clearly see. You should clearly see so this amorphous connective tissue area called the pars flaccida. You should always see the elbow of the malleus. You should be able to see that quite clearly. And you may get a hint of the incus. You obviously can't see the stapes at all in these images. Note also, pay very close attention. How would you guys describe that tympanic membrane? What words would you use to describe it?
Translucent.
Translucent, great. What else? Pearly. Beautiful word, yes. Pearly gray is my favorite word. That's exactly what a tympanic membrane should look like. It should look pearly gray, shiny, crisp cone of light. That's the kind of nomenclature that you should be using during your documentation. And of course, if I were facing this way, the cone of light would be, again, towards my nose. All right, makes sense? All right. So I just wanted to give you a little context. Smallest bone in the body is the stapes, and that connects to the oval window in the cochlea. I just can't believe how small that tiny little bone is. Some really interesting pathology happens with that little bone, particularly with barotrauma, when you've been working with rugby players and they do one of these on the pitch, which I've seen before. You can actually fracture the little tiny, these little struts. It looks like a horse strut, doesn't it? But you can fracture these tiny little struts right there and cause problems with a fractured bone, and I have no idea how you fix that. But the findings on examination will be actually quite clear, and I'll show you an example of that. So you've got this tiny little stapes bone and some interesting pathology like otosclerosis. Think of otosclerosis as being a stiffening of the articulations between the malleus, incus, and stapes can actually happen and cause some hearing difficulties. Okay, we've got a break, and in about 5 minutes, we've got tea, I believe, right? Tea? Yes. So let's switch to some questions. Fantastic question. I've got the first question's about patients using, excuse me, Valsalva instead of using an insufflation device. Well, if they can perform that, that's a possible thing you could probably do. I don't think that you're going to have the connection between the eustachian tube and the middle ear is not this sort of wide open tube. It's not a big patent tube. So if you do a Valsalva maneuver, you're not necessarily going to get that air pumped up to that area and actually clear and create some movement in the tympanic membrane. It's much more reliable to actually use an insufflation tube instead. I'm actually going to show you some interesting cases with Valsalva later on for some ear pathology. Thoughts on tympanometry? I can't say it, but I do have a discussion on it later on. Can you explain the bony growth into the external ear in cold water surfers and divers? Yes, I'll be discussing that later on after tea. And interesting students' lines, do you read palms too? No. All right. So I think that because the next part is going to be a big wallop. I'm going to slam you guys now. I think we should take a break right here and come back in, what time do we come back? 2:45. All right. Thank you very much. Any other questions at all, guys? All right. How have you been? Good. Tired. So, thank you. So you're hearing what's happening, right? That I'm leaving?
You're leaving?
Yeah. So my brother-in-law, a couple things. So
Your brother's not very well.
Yeah, he's got pancreatic cancer. So that sucks. So I basically need to be able to leave whenever like in a drop of a hat.
Yeah.
I don't know if I'm going to actually be palliating him or not, but because healthcare in the United States is very expensive when it comes to palliation. So I don't know what's going to happen, but I was hoping that I've been talking to Shannon and saying, listen, can I just do? He's been supportive of it, but saying, after he dies, which is probably in the next couple of months.
They expect you to come straight.
I'll probably spend a couple months in the United States. Yeah. No.
Please tell me that he's not telling you.
No. They've been really good about it, but like basically I said probably casual, but like. So how are things going otherwise? Really?
Yeah. I'm like, let me put it this way. I'm looking for a job.
Oh yeah?
Yeah.
What's going on?
That's the issue. I don't know what's going on.
I know.
Yeah.
Weird people are being sacked.
Yeah.
Like
important people.
yeah, Mel.
Yeah.
Yeah.
That have been fired that have been called people to get like funding and like, cause she's my friend.
Oh, is she? I didn't know
Yeah,
that.
so she's one of my really good friends. So I've got, so I'm a bit, my way of thinking is a little bit different than other people. Because I know she's stood on a lot of people's toes and all that, but then I'm saying that she's done a lot of good stuff as well.
And that's the thing, is like, I think that's where that lack of transparency has been bothering me. It's not why I'm leaving financial litigation, but it's, I am concerned about the fact that, listen, Mel, I did not like it when she would come up into the community in a dress.
Clinically, she used to irritate the fuck out of me because she had no idea what we were responsible for or what we were like, legally.
But what she's done is
but
the
what
bigger
she
picture.
said, like, so they basically made me redundant. And then 2 days later, she secures, finds out that she had secured another $3 million for me in Ireland.
Fucking fuck off.
Yeah.
Well, then they better put that fucking money into that.
So, and that was for housing and for building and all that sort of stuff, and they still think proprietary here, but
I can't believe Renee did that.
oh yeah, but in like, in because,
Sorry, one second.
Oh yeah.
Are you waiting for me? Oh, okay. No, it's working really great. Thank you very much. Yeah. I did mess with your computer settings, though. Okay. Because otherwise it wouldn't have worked. So, yeah, just to let you know, if you get some complaints, it's because I've been messing with things. Okay. Thank you. All right.
Yeah, and there's a lot of changes that no one knows what's happening. Like they've done a restructure, but no one knows about the restructure. And with the restructure always comes questions and like, maybe and they haven't really addressed that. They just keep on putting off and off and off, and then people are expected to just, like Anthony and, higher up, like the directors are expected to try and de-escalate these concerns when they don't even know what's going on themselves.
It's interesting because I know of Renee through some work she did with nurse practitioners in Brisbane with a homeless clinic, and the things that they've done were amazing. Yeah. And I don't know, well, obviously the buck stops with her, so she obviously has something to do with this. I feel like, for example, some of the iCloud, so the cloud newsletters that are coming out. Actually, they're not relevant, and and
like I've met them last. I'm like, okay, why are we even here? Because it's above our head, like for the ones that are working on the ground, like that. And then I'm thinking, no, this isn't really even relevant for like Mornington Island and Audiometry when all the systems go down and that, what happens. But yeah, and because I miss being on the floor as well, because they've taken me off the floor because I don't get on with certain people.
Oh, really?
Yes. So they've taken me off the floor, and now I'm doing the clinical governance and the policies and procedures.
Do you like that?
I'm learning.
You're good at it.
To like it. It's just getting my head because it's a totally different. Because I know what needs to be done on the floor, and I know that there's no structures that are behind me to back us up exactly what you were saying before. But I was hoping to use you because I really like
but what I've told them is, I said, like, use me. I might be in the United States, but I'm happy to, I'll probably need to actually do some of the stuff to keep my mind off
because I
it.
was saying to them, I said, because we've had meetings and I said, I love Chris's letters, I love all of them, like everything, and I said, what I want to do is I wanted to actually push it out across all the clinics that they should have one, which was we were going to use yours, which I had to ask you, and then I was going to ask you to help, because I've read your things, you're very good at writing and specifying things, so I was like, but then you're leaving. I was like, oh no.
Yeah, no, and the thing is for me, like, I gotta say, like, when I first met you and, you came out, you're crazy, and I was actually, I actually like the people that I'm working with. And it's also the most satisfying job I've ever had. But I have concerns about what is the leadership doing, and this whole thing with Mel, like I said, I didn't like it when she would show up in the community with her little short dress. but I also knew she was good.
Yeah.
You know, and that's why I gave her time, and I rate her. I rate her definitely. And we all do funny things. I know that, you know, that puts people off, but you know, she was a key driver, and it's a big call to get rid of her.
And halfway through transition, like I just didn't understand it. Like she just gets, because she actually talked to me because I was talking to you today. So she was actually in my mindset, right, the day before she found out. So she gets an email say to her that there was a meeting with CEO and Roxanne. Now, we both know when you're being called in for a meeting with the CEO
You're fucked.
and HR, it's not looking
No.
too good.
No.
So she talks to me on the way out. She goes, "Do you think I've got anything to worry about?" And I said, "Why are you in trouble? Have you been performance managed?" And she said, "Never." Has she ever been concerned about anything? No. I said, "Well, if you're worried, just get right run in that room." So she runs over to me. I was there. She goes, "Hey, just wondering if I've got anything to worry about tomorrow." So, you know, teleconference, because it was still a teleconference thing. And she goes, "No, not at all. Why do you think that?"
That's fucking weak. That's fucking weak.
Yeah.
That's fucking weak.
And I was like, so she was so happy.
You know what? She would have a legal case if she wanted one. She could for unfair dismissal.
She likes her garden. She does have a legal case.
Good.
She doesn't want to do it.
She doesn't.
Still wants to work with a management. She might, wanting to live in the East, she's got to be able to work hand in hand with Gidget Health. So she has a concept about Gidget Health. And there's a lawsuit against it. She knows that she won't be able to go back.
That makes me so fucking angry. That was weak. That's not a sign of a leader.
So then, in the arrangement, like, I don't understand why they never said to her, "Look, can you stay so we can discuss it?" Oh, yeah, no, you go.
We work together. Yeah.
Jenny, I asked a question about that.
Oh yeah, let's be sure. Yeah, let's be sure.
The reason I asked that question is because I was speaking to someone earlier from New Zealand.
About Valsalva? Oh, or about.
Who said about the suctioning versus syringing.
Yep.
Apparently in New Zealand, she was saying they've moved away totally from syringing and gone to suctioning only.
Yep.
So I'm really curious.
So I'll get to that in a little bit, but basically.
I just wanted to give it a background on that question.
So we. I'm on. Oh my god. How much did you guys hear of that? Yeah, no worries. Did you understand the asking? Okay, so yeah, they do it. Yeah. It's quite common to it's OSCE, OCE. Yeah. So basically, the whole purpose of OSCE is for you to say, yeah, it's basically a checklist. It's to say, okay, it's more than just saying, oh, this is how you do examination. Anyway, but it's more than just that. It's actually saying, okay, when I actually do my examination, I'm going to look at and do this. And the examiner's going to say to me, what happens if the patient complains of pain when you do this? They say, I'm not just doing it. That's all the osteoporosis. It's saying, you have to do, and it's basically a documentation. It's and some key things that should and some extra things are like, not everybody, for example, yeah, helping with that also. Either that's, you definitely have to do this, you definitely do this, but this is extra. So you have basics, forward things, always beyond that. And it's a good to say, after you've done that, you're confident about the theory and the practice. OSCE, objective.
Yeah, so I'm interested in that, and I think that's what
So it's something to think about. Alright? Does it make more sense?
Where did you go? Oh, you guys have leaps and bounds about the way that they get something like that. It's like it's like the when something really bad happens, we get because you can teach us how to do
Hey. So I can't describe anything.
No.
But yes, I'm gonna tell you what's going on.
Yeah, carnival or something like that. That's what my friend was
I
saying.
was going to be doing
She's up there. She was saying, she's really passionate about it because she was and she's got that
this slide right here. Oh, bugger. Escape. Anyway, one of the slides was I basically want to say, we have. Why is it so thin? It's basically so we've got jurisdictional scope of practice. We've got individual scope of practice. This layer of of crap in the middle, and that stops us from doing what we do well, and so that's how it was originally framed. And I've been trying to realign myself to the objectives of being happy. It's just like, it's about saying, like, we've got this professional scope of practice, and then we've got jurisdiction that actually narrows your scope of practice. And then we've got organizational practice that you each other, So, but I can't say that. So I'm trying to flip it around a bit. But yeah.
Because I was going to say, because one thing they're always confused about is if they need a certificate and so something that we've always kept saying to them is saying, well, no, you don't, but you need to make sure it's within your scope of practice.
Yeah. And how do you determine that?
Yes. Exactly.
You.
Yeah.
So, and so if you think that, this is going to be enough, and it's giving you the confidence and knowledge to do it, then go ahead. But if, it's about the individual saying, this is what I feel comfortable doing. But at the end of the day, there's also the recognition that my it's reaching. Maybe a lot more broad than yours. It's reaching. And so there's that comfort level. But I don't know how to actually say that.
Go into that with it. Well, I was going to say, like, I mean, it might be useful just to direct them to the NVA website and just say, but purely because they've got like a scope of practice guidelines that we kind of think the decision maker framework. But also, when you're talking about scope of practice, they actually go into how to define it. Because that's one of the things that they come out with is, am I confident? What do I know? So you kind of define it as we need to my GP told me how to do this, or I think my nurse told me how to do this. Is that okay? And I'm like, well, is that enough for you? Is that, when was the last time they updated their scope of practice? So it's bringing it all back to
I'll make a mention of it a little bit today, but I'm actually going to talk more about that tomorrow.
No, that's right. I was just thinking for the session where they're saying, do I need a certificate for the definitions of scope of practice? And you know, there's no certificate.
And what I'll say is this. Those are two things. Also, as part of your process for you're supposed to do it. That evidence of saying that I attended this conference, I attended this session, this is what I think about, this is how I'm doing my practice, this is what I'm going to do when I get back. That's what I want to see.
It's just like there are people who are privileged to come to the clinic. So a lot of people who are expecting like all these things here. I've worked in my life. And things don't go when they've got a time. Some doctors,
The one thing that's missing from this is that these are the nervous
And it was, but to be fair, it was.
We're going to start right now. Okay. Hello? Hello? Okay. I think this is working. All right. Okay, part two. All right, so you guys are now all caffeinated. You've had some cookies, biscuits, and you're feeling fabulous. So, next bit is ear screening. Now, before we go on, I just want to kind of address some concerns that I've heard in between these sections. The first is, will there be a copy of my slides? I will provide an abbreviated copy of the slides. Some of that stuff is my own personal IP, so, but I'm happy to provide, because if you go onto the internet, it's really hard to find some of these images, and that is what I'm happy to supply to you guys as far as the images of the otitis media, you know, and things like that. But some of that stuff I've really worked hard to actually get. But I'll provide a basic framework to APNA. Yeah, and they can they can distribute to you guys as required. And it will provide you with enough information that you can be like, oh, yeah, that's what we learned about that. Oh, yeah, we learned about that. So just to be fair to you guys, because I don't want you madly scribbling, I want you actually listening. The second thing is about certificates. I'm going to talk about this a little bit more tomorrow about scope of practice and demonstrating your scope of practice. You absolutely categorically do not need a certificate to demonstrate your competency. The whole idea of this course is to build a baseline of knowledge and information so that when you go back to your individual workplaces, you can say, right, I'm going to do the APNA ear training program. I'm going to use their pre-made templates for my clinical governance framework. I'm going to perhaps design my own little mini objective structured clinical examination with my general practitioner or my nurse practitioner or my advanced nursing colleague to identify what it is I need to do to demonstrate competency. But having a certificate does not demonstrate competency. And the NMBA, I'm not speaking on behalf of the NBA, but I am speaking on my own behalf saying, you know, I've met some really amazing people that, you know, have a great deal of competency and have no qualifications and have, you know, no nurse practitioner license, no, you know, nothing, you know, as far as advanced endorsements or anything like that, but they're amazing nurses that I look up to. So a piece of paper doesn't prove your competency. And I would say that the thing that you best can do is actually use, when you're demonstrating your competency for ear syringing, you're developing your framework in this program, are the learning outcomes from this session, which is what you need to actually use for your reflective piece for your CPD. And then you write up a bit about what you learned from the session and then what you're going to be doing in the future to address any knowledge gaps or experiences that addresses your competency. That's how I would approach it, okay? But having a certificate from the session is worthless. It means nothing. You and your knowledge gained from that means everything. Does that answer everybody's concerns appropriately? Good. And if it doesn't, come to me afterwards. So here we go, ear screening. So we've talked about looking at the APNA and then talking about the basic otoscopy exam and about that wonderful installation device that you're all going to go out and ask your practice managers or you're going to buy yourself for your own work. But now I'm going to be talking about why we do ear irrigation. Why, you know, you just don't do ear irrigation on somebody that has a little bit of wax in their ears because the risks of doing that procedure far outweigh the benefits. And I think I've shown you some of those reasons why those risks outweigh the benefits. But as part of your examination, I want to challenge you now about saying, is ear syringing about basic ear syringing, or is it actually doing a comprehensive assessment and saying, how is this wax really affecting the person? This is something called the Rene and Weber test. Have you guys who here has heard of Rene and Weber? Right, so today is learning outcome is to look at this test and see how you might apply this in the process of assessing your patient for the need of getting ear syringing and whether or not ear syringing was actually successful in resolving their hearing loss as a result of the earwax, all right? So this is a simplified instruction of Rene and Weber.
Here's a really simplified drawing of the hearing system. You have two ears. In this case, they look like little Mickey Mouse ears. Then you have a blue ear canal, some red ossicles, and a green cochlea. I've labeled that for you here by colors, just so we can keep this really simple. There are two types of ways that we conduct impulses to be able to process them through cranial nerve 8. One is through air conduction. If something is held right in front of your ear, it moves through the air into your ear and is conducted on its way towards the brain. The other is bone conduction. If something is held against the bony process of the skull, sound waves move through the bones and go directly to the cochlea.
And that makes sense because when we talk about, you know, the most efficient way of transmitting sound to the cochlea is through the air and vibrating against those waves, vibrating against the tympanic membrane and jiggling those little malleus, incus, and stapes that in turn conduct impulses through the cochlea. And so air conduction should always be better than bone conduction. And bone conduction, the theory of that is actually based upon what? Have you guys ever seen those hearing aid devices? Yeah. Cochlear implants, which was an Australian technology, by the way. Did you guys know that? I didn't know that. Anyway, so yes, so keep on going. Here we go.
Under normal circumstances, air conduction is This makes sense. If something is held right next to your ear, it's going to be louder and more audible than if it was held against your skull. Now, let's say that we place a tuning fork on the mastoid process. You need to know whether this is the Weber test or the Rennie test. The mnemonic to remember this is that the Rennie is under the pinny. So if you know that the outside of the ear is called the pinna or the pinny, Rennie under the pinny. So anything under the ear, it's the Rennie, because your Rennie is under the pinny. So what you do is you strike the tuning fork and you put it under the pinny or on the mastoid process. And then you ask the patient to tell you when they can hear it. They tell you that they can hear it, and then you move it right outside the ear. So what you've done at first is you've tested bone conduction with Rennie under the pinny. Right outside the ear to test air conduction.
I just want to reiterate that point for doing the Rennie, is that when there's two ways of doing the Rennie, all right? One is as he's explained. You take the tuning fork and you ding it, and then you place the base of it right next to the mastoid right here. You can do it on the temporal bone right here if you want, as long as it's near the ear, and it's actually a pretty firm, not painful, but it's pretty firm pressing against the bone, all right? So what happens is that the way that he's explaining it, the first way of performing the Rennie is you put it right here, and the moment that you've struck the device, you put it underneath the ear, and you say, "Can you hear that?" And they say, "Yep." Now, is it louder here, or is it louder here? Okay, so you bring it about an inch, 3 centimeters away from the ear canal, okay? So basically what you're doing is you say, ding, you hear that? Yep, okay. Is it louder now, or is it louder now? And if it's, say it's louder now, right next to the ear, that's normal or abnormal? Normal, great. The second way to perform the Rennie is to simply, because air conduction is greater than bone conduction, is ding, and it goes right here, and you wait for it. Tell me when you can't hear the noise anymore, and you're pressing it against the mastoid or the temporal bone, right? Ring, and it goes away. All right, it's gone away, and then you put it right here, right in front of the ear, and the patient should still be able to hear it because air conduction is better than bone conduction, okay? Two ways of performing the Rennie. I prefer doing it. It's quite subjective when you say, which one's louder? You know, it's a very subjective experience, and there's some interrelated issues with actually performing that test. But when you do it the way that I've explained, where you put it on the bone, tell me when it stops. No? Okay. Can you still hear it? Oh, that's an abnormal Rennie, okay? If they can still hear it.
Double check to see if you can hear it yourself.
No. Yep. Yeah. That'd be kind of, yeah, I can see what you're saying. No.
How do
Good, yeah.
you make sure that it is still ringing?
You can try it on yourself first and see, because there's also a little trick of, some people smash that thing and it goes, it's going forever. You're just sitting here with this on your bone forever, and then you're like, okay, but you just get used. The more that you use this test, the more that you actually become comfortable with saying, this is how hard I had to strike it. It comes with experience, okay? Keep on going. Oh, no, sorry.
Bones and go directly to the cochlea. Under normal circumstances, air conduction is greater than bone conduction. It's going to be louder and more audible. Now, let's say that we place a tuning fork on the mastoid process. You need to know whether this is the Weber test or the Rennie test. The mnemonic to remember this is that the Rennie is under the pinny. So if you know that the outside of the ear is called the pinna or the pinny, Rennie under the pinny. So anything under the ear, it's the Rennie, because your Rennie is under the pinny. So what you do is you strike the tuning fork and you put it under the pinny or on the mastoid process. And then you ask the patient to tell you when they can hear it. They tell you that they can hear it, and then you move it right outside the ear. So what you've done at first is you've tested bone conduction with Rennie under the pinny, and then you've moved it right outside the ear to test air conduction. Again, under normal circumstances, air conduction should be greater than bone conduction. If they have conductive hearing loss, they'll be able to hear it better when it's held against the bone, when it's under the pinny on the mastoid process. But our mnemonic to remember the Rinne test is Rinne under the pinny. There's another test that you have to know. If you place the tuning fork, if you strike a tuning fork and place it on the top of the patient's head, this is the Weber test. The Weber test localizes ears. The Weber test tells you whether it's the right or left ear. See what I did there? I replaced the word weather with Weber. So the Weber test tells you whether it's the right or the left ear. When you strike a tuning fork and place it on the head during the Weber test, the sound moves to both ears. So this is for localization. Under normal circumstances, the patient should be able to hear the sound equally in both ears. But if they have sensory neural hearing loss, they're not going to hear it in the ear that has sensory neural hearing loss, which means it localizes to the good ear. In other words, if I strike a tuning fork and do the Weber test and place it on your head, and you only hear it in your left ear, that means that your right ear has sensory neural hearing loss. So Rinne under the pinny and Weber tells you whether it's the right or the left. So that's a lot of information in a very short amount of time. So why don't we do an example? If a tuning fork is placed on the mastoid and then moved outside the right and left ears, the patient says that they're able to hear the tuning fork better when it's held in the air next to both ears.
Is that normal?
The physician then strikes the tuning fork and places it on the patient's head. The patient says that they hear the tuning fork better in their right ear. What is the diagnosis? So I'm asking you what type of hearing loss is present, if at all. So let's dissect this step by step. The first thing that the physician did was strike the tuning fork, place it on the mastoid, and then move it outside both ears. He started with the mastoid. That's Rinne under the pinny. So he did Rinne under the pinny, and the patient said that they were able to hear the tuning fork better when it was held in the air. That's a normal response, because again, air conduction should be greater than bone conduction. So we have a normal Rinne test. Then the physician struck the tuning fork and placed it on the patient's head. What test is that? Well, that's the Weber test. It told you whether it was the right side or the left side. When the physician did this, the patient said that they were able to hear the tuning fork better in their right ear. So the question is, which ear has sensory neural hearing loss? And that is the left, because the patient heard it better on the right side.
Okay.
So here, that was just a really easy example, but it goes to show you how simple these tests are if you know what the tests are testing for. In a nutshell, if I'm going to summarize all of this for you, I would say that the Rinne test is Rinne under the pinny. You put it on the mastoid just below the pinna of the ear, and you're testing for conductive hearing loss. The Weber test is testing for sensory neural hearing loss. It tells you whether it's the right side or left side that has sensory neural hearing loss.
So what is the relevance? So at the end of the day, conductive hearing loss is hearing loss that's usually due to a cerumen impaction, particularly when we're talking about younger persons. When we talk about the age of the hearing loss that's associated with age or presbycusis, that is more sensorineural, okay? There are other types of, so there's mixed hearing loss, there's conductive and sensorineural, but at a very basic level, when you have somebody with conductive hearing loss, which is what you would evaluate using which test? The Rinne of the pinny, yeah, exactly right. You'd be using the Rinne to actually help first evaluate whether or not this is a conductive hearing loss. And if that was a normal examination, then there's probably no problems with earwax, no issues with otitis media, something that's impeding the sound waves from getting to the ossicles, okay? If it's sensorineural, when we do the Weber test, that helps us evaluate whether this is a sensorineural issue. So the reason why this is important to you is because there are lots and lots of very expensive equipment that you can buy in general practices. And really, from a screening standpoint, one of the most important things you need in general practice is a tuning fork. And the number of general practices that don't have a tuning fork, particularly when we're talking about middle ear disease in children, is shocking to me. And the number of practices that don't use the tuning fork because they don't know how is also shocking. You guys are now the experts. You can go into your general practices and say, I want to be doing a comprehensive hearing assessment on my client. Your hearing assessment on your client could start off with doing a whisper test, where I'm saying, 1, 2, 3. What did I just say?
1, 2, 3.
1, 2, 3, 4. What did I just say over there?
1, 2, 3, 4.
Okay. So, or it could be the this test. What, do you hear that?
Yeah.
Do you hear that? Simple. That's your basic screening test. But then when you start talking about a hearing problem suspected to be due to conductive hearing loss because you think there's an occluded earwax in there, you've looked in there and it's completely occluded, you could do Rene and Weber. And my suggested approach for this test is that you first do the Rene. If that's normal, that means that there's no conductive hearing loss. That means that there's nothing that's stopping the sound waves from getting right into the cochlea, all right? Once that's normal, then you do the Weber, because then if the Weber is abnormal, you might have sensorineural or cochlear or cranial nerve 8 hearing loss issues, all right? So this is sort of, I will include this part for taking home with you as far as the handouts, because I found that this way was actually a more straightforward way for you guys to actually learn how to use this and implement it in practice. They do recommend there's different types of tuning forks that you can get. This one right here, the purpose of this is just for holding it, okay? You can get a fancy one that has a foot plate like this. There's nothing magical about that foot plate. It just feels better when you press it against somebody's bone, okay? You can get the normal tuning forks that are just a little wink, this little thing, you know, that's fine. They work. They're just not as comfortable for patients. And the last note that I have for you is that correct technique for performing the Rene is the tuning forks, the tines should not be like this to the ear. They should be like this to the ear when you perform it, okay? And that's because of the way that, actually don't know why. It's just, I was gonna pull something out of my butt, but like, all right. All right, so moving on. All right. Yeah, exactly right. I've done enough. All right, so audiometry, I do think that there is a definite role for this in general practice. There's actually an MBS item number that's frequently underutilized that are associated with a basic screening audiometry. The hearing devices are not expensive. I would recommend that you do think about your general practice as buying one and getting some training on audiometry. I know basic audiometry. I do not know threshold testing, for example. I am not an this is outside of my scope of practice. Okay, well, just full disclosure. I do know enough to get me in trouble, and I do know that when we look at audiometry, we're looking at not only the pitch usually from 500 to 4,000 hertz. So the pitch, high pitch, low pitch. We're also talking about the hearing intensity. So intensity being loud American and soft-spoken Australian, all right? So when we talk about audiometry, we know that the thresholds for normal hearing, for normal adults that have a normal speaking voice like this is about 25 to 30 decibels. And of course, with those young children, with those young healthy cochlea, they will have slightly more sensitive hearing, and they can have a lower intensity before they can pick up thresholds for hearing. You do need a quiet environment. You usually do 5 years and up because just from a test repeatability standpoint, asking them to raise their hand whenever they hear a sound, 5 years is where I personally have a lot of success. I said a lot of success. I have had some success with younger kids. Younger than that, it's really, you get hands waving everywhere when you do the test. So these are the standard frequencies that people test at. And just be aware that if you are saying, oh, I'm testing at 4,000 hertz, and oh, you still haven't heard it? Well, I'll turn it up a little bit. I'll turn up the intensity. The moment, they still can't hear it, and you keep on turning up the intensity until you hit 40 decibels, at that point, you can actually hear it in the other ear. So just be aware that you can have problems with saying you can hear a sound. That's because your other ear is hearing that sound, not your ear that you're testing. And that's where masking comes in, where you put the headphones on, you're testing this ear, but there's white noise going on in this ear to help with, it's called masking, all right? Who here actually performs audiometry routinely in general practice? I would love for you guys to actually do a session on this for an APNA conference so that I can come and learn, because I feel like I don't know enough about audiometry.
Chris, I think it's the quiet environment that's the issue.
Yes.
Because I worked in defence health and there was an actual closed booth.
Yes.
But in general practice, it's just a set of headphones.
Yeah.
So, like in general practice, I've only done it with, in the places where we do the workplace health assessments.
Yeah.
And it's essential, but I think it's dodgy ass.
Yeah, and I would agree with you. If you're saying that this is a diagnostic examination versus a screening, and this is the difference, is that we're talking about screening examinations, and you've hit the nail on the head. You have to be in a very, my background's in cardiology. Like listening to heart sounds, even in a general practice environment, can be very difficult. So you really need a quiet, and these soundproof rooms are ideal, and that's actually what's performed when you do go to an audiologist. But this is about screening. And I'm talking about early intervention, like screening is a great tool. This is a terrible tool for saying, yes, you have sensorineural hearing loss or conductive hearing loss at these frequencies. That's your diagnosis. Then you're getting into a medical legal nightmare. This is saying, is there potentially a problem? Okay, make sense? I would challenge then you go into screening for middle ear disease. And this is a relatively new technology for me. Who here has used tympanometry? I can't say it right, good. We, at our practice, when I came into our practice in remote Australia, I started using this device. At the end of the day, I still think that doing a basic otoscopy and making sure that you're doing a Rene and Weber is really important. Doing hearing screening is really important. But this device is pretty darn amazing as far as helping you diagnose middle ear disease. Like I told you before, you can look at an eardrum and it looks completely normal. But the moment that you insufflate them, you see that because they've got so much fluid behind the eardrum, when you press air that way, it's either sluggish or it doesn't move at all, which is a very painful drum, okay? They do use, this device is used, I don't know how expensive it is, but it is a remarkable little device because it can serve as an alternative to pneumatic otoscopy, and it can help you identify things like eustachian tube dysfunction, where you've got an upper respiratory tract infection, it's sealed up the eustachian tube, and you now have a negative pressure behind the tympanic membrane. The pressure behind the tympanic membrane should be equal to atmospheric pressure. So it's great for acute otitis media somewhat, but it's really beneficial in those cases of glue ear where we're seeing problems with hearing loss that are being translated into learning difficulties and behavioral problems because these poor kids have glue ear that's been underdiagnosed. I would say, however, that I had my own clinic. I don't think that this is worth it. I think that that's a waste of money, and I would just get myself one of these because the research shows that the sensitivity and the specificity with this device is better than this device because you're actually looking in the ear, doing the insufflation, and seeing in real time what's happening, whereas this device doesn't tell you exactly how that thing is moving at all.
Do you have to have a seal to use the
Both.
pneumatic?
Both you need a seal. Yep.
So what if you can't get a seal?
Appropriately with that,
Yeah.
change your speculum. Go to a larger speculum. Does that make sense?
Yeah. But what about if people have really
Really, really large ones?
Yeah, like you're either going to go in too far and into them or...
That's good. That's a good question. I think that from my practical experience, I've found that a large specula for this one usually does the job. However, if you've got cash, get one of those. But the evidence does show that the sensitivity and specificity for this basic, cheap device is better than this. But again, for somebody who's a novice practitioner, this is also a lifesaver, this tympanometry device. Yes, go ahead.
So you can actually get speculums that have like a silicon bulb on the end
These.
to fill in those gaps.
Are you talking about for these speculas or for these speculas?
Yeah. Yeah.
Those ones?
Yeah.
I haven't seen those.
They're expensive. They're about $60 or something for a set of about 3 different sizes.
Are those, so they would have to be autoclaved then, right? Wow. Yeah, I've never seen those in practice. Again, if you're cashed up, go for this device. It's a really fantastic device. I would say that this, I've never seen those little gaskets. I'd probably check into that, but from a price perspective, we don't have an autoclave, so Yeah. All right. Moving on. Break. Questions? Sorry. Let's see if there's any questions here. Okay, first question was, are we right to refuse doctors' request to syringe patients with full cerumen occlusions with active otitis, media, and or fungal infections? Yeah, I wouldn't be doing that. The reason why one of the indications for ear irrigation is that you can't properly assess the patient because the wax is getting in the way. That is actually an indication. I would say that is, what is wrong with empirically putting antibiotic stewardship to the side for just a second and saying, okay, we've got a kid here who's got symptoms of otitis media. He's got a fever, he's got pain, he's got adenopathy to the neck, he's got a swollen throat. At the end of the day, you're going to treat this kid with antibiotics. That's how I would treat this kid. And at this point, is it important to be assessing the tympanic membrane? Can we do that at a later time? That's a very legitimate thing to ask. And if you explain that to your general practitioner who you're collaborating with, that's a reasonable, rationed argument. And at the end of the day, you can always say, I don't feel comfortable doing that. That's part of your scope of practice. So that's an excellent question. And I've actually had poor nurses exposed to that situation where they've been told to do something that they're not comfortable doing.
But Chris, if you've got that in your policy and procedure,
Yep.
so for example, we know who you're referring to that presents the only oral health irrigation course, and they've got very clear, do not syringe, it's contraindicated, and one of them is a recent infection in the last month.
Yeah.
When high risk, so it differentiates,
Yep.
and that helps to say to the doctor, it's actually against that policy.
Correct. And I think that's actually a really good and reasoned approach. Is how it should be, this issue, which is common, should be addressed somehow in your clinical governance framework. If you were an ENT specialist and this person was being presented to you with an ear issue and you couldn't see the cerumen and you suspected that there was an ear irrigation, they'd be suctioning that patient out, all right? Not irrigating that patient out. I personally do not feel comfortable doing that in an active infection, and I think it should be addressed in your policy. I would say that training course is a vet training course. It's meant for enrolled nurses, for Aboriginal health workers. You are at a different level of practice as registered nurses. Some of you guys may be enrolled nurses, but at the end of the day, I think that it's your professional license. It's your registration. And if you're not comfortable, nah. And you'll see very clearly later on in my slides, I make it very clear, you should not be doing that, all right? I can see why the general practitioner wants to do that. If you have a reasoned discussion with them saying, I don't want to do that, I feel it's outside my scope of practice because I feel that an active infection, Chris Helms said that ear syringing is contraindicated during active infections. Can we treat the client empirically because of their symptoms and perhaps bring them back for ear irrigation when they've resolved? That's a good discussion to have. But I personally, I want to be very clear. I don't think that syringing during active disease is ever indicated, and I would never do it. Pretend it's your kid. What would you do? When you've seen pictures of otitis externa, malignant otitis externa.
Their guidelines actually saying not within the last month.
Yeah. And I think that's, quite honestly, how long does an otitis media take to resolve? A long time. And I'll show you some pictures later on about how long it actually takes for an otitis media to actually resolve. So, tuning forks versus pure tone audiometry. So, tuning forks are again a screening test. They don't diagnose yet with anything. They say, hey, you have symptoms of sensorineural disease. You have symptoms of conductive disease. And I can try to do the ear syringing and see if it resolves your conductive symptoms. However, really, from a diagnostic standpoint, from a diagnosis standpoint, you need audiometry, right? Does that make sense? Yep. It's a screening test. We use screening tests all the time. The DAS, the Edinburgh Postnatal Depression Scale. This is just one other screening test. All right. Hawk Library has free images. That's exactly where I got my images for this presentation. It's a dirty website as far as it's not a dirty website. It's a I have a background in website design, so it's just a very cruddy website. But Hawk Library is where I got most of my images in this presentation, and has really high quality, high res images. And if you know how to navigate through the web to get those images, you can get all of them, and there's some massive, amazing images there. Nurses have fought to receive recognition as a profession, dismissing postgraduate pieces of paper, including MP qualifications, offensive to those who fight. Fair enough. Listen, I absolutely have fought to get to where I am at as well. I had my MP licensure. I was an MP in the United States, came to Australia, and fought for 2 years to get my MP endorsement back. So I understand about the difficulties of getting back into the profession and having that piece of paper that says, yes, you are endorsed. No offense was meant. However, I do think that saying that you have a piece of paper that says that you're competent is, at best, in my opinion, naive. And the reason why I say that is because there's a huge body of research which actually informed the CPD portfolio for nurses that says that basically performing a CPD activity in and itself relates to zero outcome as far as improving practice, as far as protecting the public or making discernible differences in morbidity and mortality. The research base for that is huge. And it's based upon the fact that people just go blindly into CPD and and I've been guilty of this myself, where I've done an online activity and I've just gone through and just did the online activity, and I got my little piece of paper and I said, yep, done, and I did that for the board. I've done that, you know? I think a lot of us have done that. And it wasn't until, I suppose, I got later on in life, I realized that actually it was going in one ear, sitting and just stagnating. It wasn't doing anything with the information. So I would challenge you to say that, no, I'm not saying that piece of paper is worthless. What I am saying is that you should consider actually thinking about whether, yes, that certificate for your endorsement, very important. Mine was very important as well, still is. But is that certificate meaning that you're competent to do a procedure like this? All right? Would you feel competent getting a certificate saying you're good for doing skin biopsies or skin lesion excisions just because you went to this course and you listened to me talk about surgical techniques? Would that be sufficient? Are you competent? No. You need experience to back that up. So apologies if I offended you, but fair call. Fair call. I'll give you credit for that. Anything else? Let's see here. Can the Rinne and Weber test? Yes, absolutely. They can be performed on children. The tympana, I can't say it. Yeah, it doesn't work. The eustachian tubes, and the ear canal is too floppy and young infants and things like that. So I wouldn't recommend it in young children and infants. But otherwise, Rinne and Weber can be used if you would like to. All right. Any other questions? Fair call. I would say that whoever was offended, please come up and talk to me afterwards, because I wasn't intending to do that. I apologize. All right. So moving on. Pathology. This is the part where you get grossed out, and hopefully it keeps your interest, because we are finishing up at 4. Okay. Wow. I've been blathering on for a long time. The wonderful world of earwax. So the color and smell of your cerumen is partly determined by your ethnicity. Well, I did not know that. And it explains a lot about the populations I've seen when I was working in the United States and working here in Australia, why some people just have different types of earwax. We do know that people from Mongolia and from East Asia do have a more flaky, golden-colored earwax. Even if it's a young, wet earwax, it's still flaky and golden-colored. Whereas people from, for example, South America, Caucasian populations, people from Africa have more of a dark, toffee-colored, sort of molasses-colored earwax. There's actually a really fascinating field of research around earwax. Actually being able to yeah, I know. Again, something that I learned along the way for doing this for you guys. If you ever want to, I'll give you this reference if you want to look it up, but it's online, and they're actually looking at how to diagnose metabolic disease and cancer, certain cancers, just from the earwax. Because again, this earwax is from an apocrine gland, and it actually is producing chemicals that give the smell. And so there's a relationship with, for example, with dogs. Dogs can smell seizures. All right, that's why we have seizure dogs. Dogs can smell cancer. Same thing. Well, some dogs, not my dogs. My dogs are idiots. But you know, at the end of the day, there's some interesting, fascinating research around earwax. And these are some of the normal colors of earwax. So again, this type of earwax you would expect in somebody from Mongolia or from East Asia. This is more typical of the wax that I've been seeing up in the place where I work. This is a wet wax. This is a dry wax. There's no evidence to support this, but I tend to have a lot more success on irrigating people out with a wet-looking wax than with somebody with a dry wax like this. I have seen this before and said, what the heck is that? Is that a tympanic membrane that's gone, you know, that's really sick? It's actually a veil of this wax, and I just wanted to provide those two images because I've seen it before and gone, what is that? So, you know, wax is great. It protects and moisturizes the ear canal. It helps trap debris. It's got a low pH. It discourages microbial growth. And our earwax gets drier as we age, and that's why we see a lot of problems in aged care facilities, for example. So with respect to this, I guess before you even consider irrigating, just think to yourself, is this something that we really want to get rid of, all right? I still remember when I first learned how to do ear syringing, I was told that any bit of wax, if it was like I was given a number, I was given 60%. If it's 60% or greater, then you should ear syringe it, and that's actually not supported by the research. You irrigate if the wax is occluding and there's conductive difficulties, basically. This is the one time that you actually say earwax is a bad thing. Remember what I said about desquamation, about how our skin normally desquamates? So this is a certain condition that individuals sometimes have, and it's called keratosis obturans. And basically it's because they don't have migratory epithelium on the tympanic membrane. In fact, they desquamate, and they're not supposed to be desquamating. And they get this really solid, like a rock in your ear. And that's all keratin and squamous epithelial cells that have actually collided together. And it gets so impacted in there that you end up getting necrosis of the canal. It can actually eat into the bone. It can cause some really, I had some pictures of how that, after it removed, what the bone looked like afterwards. So it's actually quite painful. So if you see something that's really, really, really white like that and quite firm, keep that differential diagnosis in the back of your head of keratosis obturans. I am a massive fan of Deadly Ears Queensland. Who here has looked at their website? A brilliant, absolutely brilliant website. Highly recommended for understanding more about the different pathologies that we see with ear disease. And as far as I'm concerned, this is one of my top priorities where I work up in far north Queensland, is making sure that we're addressing effectively acute otitis media and otitis media with effusion. But these are some of the conditions I'm going to be discussing today, just so that I can give you a brief overview of things that you need to consider after earwaxing or after ear irrigation. This is tympanosclerosis. This is simply scarring of the eardrum, and it's actually, quite neat. Sometimes you'll actually see where somebody had a grommet right there, and there's a little bit of tympanosclerosis right there. It is brilliantly white, very, and it's adherent to the tympanic membrane. You typically don't get rid of it. It's benign, it's harmless, it's fine, unless of course it's extended. The scarring has done the entire sort of tympanic membrane, and it's actually made that tympanic membrane, instead of being flexible, quite rigid, and that will perpetuate a conductive hearing loss. So by itself, tympanosclerosis, completely benign, don't worry about it, all right? It is something that you'll commonly see. Exostoses, somebody asked earlier on about the bony growths in the ear. Exostoses are a result of, we think, cold water exposure. So what happens is surfers, people from northern Wisconsin, where I'm from, cold water lakes, go in the water goes into the ears. At first, your body constricts, the skin, the blood vessels in the skin that cover the periosteum constrict. And then what happens is that, have you ever been out in the cold? You had these hands and then gone back inside, and after about 15 minutes, you warm up, and all of a sudden your hands become brilliantly red, and that's what is happening inside your ear. That causes stimulation of the bone, and it's a process that happens over and over and over. Exostoses are actually a benign condition. We don't get worried about exostoses unless they become quite occlusive like this, because then earwax gets trapped in there quite easily. And sometimes, if you're trying to irrigate somebody with really severe exostoses, the wax can get lodged behind there, and then you end up sending them off to the ENT referral for suctioning. So just be aware that exostoses by themselves, bony gross, they're not like this. They're hard, and they're always bilateral. They're never unilateral. If you see them unilaterally, you think more of possibly something called an osteoma, which is also a benign growth of the bone and not something that you usually worry about. I would say that always double check this finding with another colleague, just to make sure that the diagnosis is correct. Foreign bodies, oh gosh, the bane of my existence. So this one has happened to me, and this one has happened to me. Not to me, but to my clients. So what is this? It's a grass seed, that's right. And what is this? It's a piece of sponge from a hearing, what do you call them? Yes. And then we got a cockroach on its back. So how do you take care of that? You can, and a big warning here, irrigation. Vegetable sort of materials, peas, carrots, the things that you commonly find in kids' ears. If you irrigate those, you can potentially cause swelling of that vegetable, and then it gets really stuck in there. So this is an example of seed that's sitting right next to the tympanic membrane, this author said that they irrigated it out. Depending on my context, if I'm in Canberra, I probably wouldn't. If I'm in actually far north Queensland, where I have very little resources, I would have irrigated that personally. Next one right here, how would you get that one out? The ear plug. How would you get that out? Tweezers, alligator forceps. By the way, I'm not advocating that you guys do this. This is something that a skill that you actually have to learn. Just giving you some baseline information so that if you see this, you can be like, I need to go talk to my collaborating practitioner, whoever it might be, and tell them what's going on and prepare some forceps if you see that, if they want to get that out. And of course, this is mineral or olive oil. I like to just pour in there, and it just floats right on out, kills them, they suffocate, and they float right on out. Okay. Otitis externa, diffuse swelling, pain with manipulation of the pinnae, blocked feeling, draining, itching, and hearing loss. This is a good example of a fungal infection. Kind of looks like the keratosis obturans, doesn't it? But when you irrigate this, it washes away. And this is something that you occasionally find, for example, behind a wax plug. What a great place to actually grow as a fungus behind a warm and moist place behind a wax plug. So if you've done this and then you discover this, well, it needs to be treated, but it's not the end of the world, all right? But diffuse otitis externa is also referred to as Homer's ear. Otitis externa can be chronic and ongoing and cause inflammation and reactive hyperproliferation of the squamous epithelium. It can actually get narrowing of the ear canal because of it. This is a great example of what you'd think would be, it's wet, it's crap is coming out. But this is actually a good example of a dermatitis. Or psoriasis could be, yes, exactly right. It could be psoriasis, or it could be a dermatitis that was exacerbated, in this case, by the chlorisig drops, okay, which are used on the patient. Okay, acute otitis media versus otitis media with an infusion. So which one do you think looks really abnormal? This one, or this one? Left, middle, or right? Left. Look at that. It looks like a outie of a belly button. It's bulging, all right? You get the sense that it's about ready to pop. Whereas you look at these two, which one do you think is normal, left or right? Right? Why did you say right was normal? It's pink. It's pearly gray. Remember that beautiful word, whoever said pearly gray? It's pearly gray. This is a sort of a brownish, and that's actually the serum, this is serous drainage in the middle ear. See how difficult it can, there's that beautiful, crisp cone of light, just like this one, all right? You can see the incus, all right, right there. You can see all the normal anatomy, but that person might have a conductive hearing loss because there's effusion behind the tympanic membrane. So yes, we've got the normal pearly gray, acute otitis media, and otitis media with effusion. We can have very sort of obvious examples of otitis media with effusion with this with the bubbles. You can see that. Again, normal-ish. There's a little bit of redness right here, some injection, but bubbles behind the tympanic membrane. You don't see that very often. And then right here, you can see this acute otitis media. It's red, it's swollen, it's pooching out. It's about ready to pop, and in fact, it's right there, and that's what it looks like after it's popped and drained. Okay? So you can see the evolution of how these ears happen, all right? This is a grommet with an acute otitis media, so it's draining pus, and there's a grommet right there, and it's draining a bit of pus right there. You can't see any landmarks at all in that tympanic membrane, and you've got these large, really unsafe, particularly this one right here, these unsafe perforations. It's outside the scope of this to discuss right now, but there are unsafe perforations and there are safe perforations. I would generally say that this right here is a completely safe perforation, but any perforation that is located up here in the pars flaccida area, that's an unsafe perforation because you can develop what we call a cholesteatoma, which is basically a little squamous epithelium that gets inside the ear and causes this little bony growth that can cause hearing loss. So a little tiny perforation right here is fine, but the moment that you're up in the attic or the moment that it's touching the edge of the tympanic, the rim basically, that's where you start getting problems with cholesteatomas. This is the stages, and this is over a period of a month. Okay, so this is actually their evolution from early otitis media, where you get the increasing vascularity. Look at all those blood vessels running into. In those previous examples, you didn't see any blood vessels on that tympanic membrane right there. There's some right there, and that's normal to find some blood vessels right here. But the moment they start getting hypervascular and start going up to right there and down across the tympanic membrane, that's early or late resolving acute otitis media. There's a clear bit of a pus fluid level right there with an air pocket right there, maybe a little blood as well behind that tympanic membrane. And after that pus resolves, then you've got this glue ear or this otitis media with effusion, and this is particularly why it's sometimes hard to identify otitis media with effusion in general practice without that little bulb. You look right here at this, it's not a crisp cone of light, is it? It's kind of diffuse. That's the kind of subtle stuff that you're looking for when you're doing your examinations. Grommets, and they, of course, do extrude right there. This is barotrauma, so this is the blue eardrum. They always use, if you ever see that, that really needs an urgent ENT referral. There's blood behind there, and likely one of the ossicles have either ruptured or there's been some sort of major trauma within the ear. This is a herniated tympanic membrane. This is just some more pictures of acute otitis media. Perforations can be huge. You can have dry perforations. You do, this happened to me once. This guy came in, I said, any problems with your ears in the past, any surgeries, anything at all? No, everything's fine. And he had a huge wax plug, and then I irrigated it, and I found, not this big, but I found a massive perforation in there. I'm like, oh, that's not good. So we had to put him actually on antibiotics to help cover him because I had irrigated him. So you do sometimes get surprised by your patients. They give you a history that's not fulsome, or they didn't even know that they had a chronic perforation, which is also quite possible. These look a lot like perforations, don't they? They look, you get this sense of your tympanic membrane being draped across the actual bones. Look at the diffuse scattering of light. There's no crisp cone of light anymore. What this is basically caused by eustachian tube dysfunction from an upper respiratory tract infection, and the air behind the tympanic membrane can't equalize, and this is something that can be quite problematic through time. This is, somebody asked about autoinsufflation or Valsalva. This is before Valsalva, and this is after Valsalva. So sometimes you have to do Valsalva to figure out whether or not this is a massive perforation or just atelectasis and eustachian tube dysfunction. You've got dried blood, which has this appearance of a dark cherry color. This is something I didn't know. Actually, I've treated this as a fungal otitis infection in the past, and now realize that it's actually a keratinization. It's basically that normal functioning of the conveyor belt. That's normal. And when you get it wet, it gets even more pronounced. So it looks a lot like a really crazy fungal infection of your ear. It looks white, but it's that striated appearance. It's actually quite normal, and it becomes more pronounced when you irrigate. This is a cholesteatoma behind the eardrum, this mass right here. And that's it. We're running out of time, so I might kind of move this ahead. As far as risk factors, hearing aids, occupations with high risk for dust and debris exposure, older persons, development delayed, particularly have a lot of problems with cerumen occlusion. If you do have conductive hearing loss, if you've got a cough, I have had problems with patients that come in. I've been treated with antibiotics. I've had my cough for 6 months. It's not going away. And nobody bothered to look in their ear, and they've got an earwax impaction. Within a week of that being resolved, their cough is gone. I have actually had that happen to me once. So you can get tinnitus, dizziness, fullness, itchiness, mild pain, even a bit of discharge. And again, cerumen can be actually quite stinky and not be infected. And sometimes they complain of an odor from their ear. So reasons for removal are these. If you have an upcoming audiology appointment and there are these symptoms, you should be consider syringing as well, because a lot of audiology appointments get canceled because of occlusive ear disease from cerumen, or if you're unable to examine the tympanic membrane and you really need to. I personally would never irrigate the tympanic membrane or the ear canal to look at the tympanic membrane for the treatment of a diagnosis, or for diagnosis for treatment. I would rather it be syringed by an ENT. It was that important. Ear cannling does not work. I mean, it's really relaxing, and I've never had it done, but my partner has, and he swears by it. So it's one of the things that we fight about anyway. So as far as this is, it's ineffective and potentially, because you've got a fire next to your ear. You do get some wax on it, but it's actually wax from the cloth that's actually accumulating. It's actually not wax that's being sucked up. There are some really, really well-designed studies that have actually looked at this, and it's complete fallacy. So I do not approve. Cotton swabs, interesting. We had an interesting discussion with somebody in the audience earlier on about cotton swabs. I personally use cotton swabs. I know I shouldn't, but I do because I don't know, I'm stupid. Cotton swabs, the action of doing that actually triggers your apocrine glands. It actually triggers earwax production. And in fact, if you look on almost every single product of cotton swabs, it says on there, warning, do not insert into ear canal. If used to clean ears, stroke swab gently around the outer surface of the ear only. Every one of those ear swabs, go to the store, look at them, they'll have that warning on them. They don't want them to be putting that into your ear. However, I would say, as far as the evidence to say that it actually causes a worsening impaction, in the case of exostoses, yeah, I could see how that would cause. But otherwise, really, there's really weak evidence to say that these are going to cause impaction, but they do trigger earwax production. All right? So one of the big questions, one of the big diagnostic dilemmas that you have to figure out is whether you irrigate or whether you just use cerumen lytics, okay? So there's a couple of Cochrane reviews looking at studies, and they basically said, whether you use olive oil or almond oil, if you use a water-based product, there's lots of things that you can buy over the counter. Saline or plain water, overall, if you use it for at least 5 days, that's more effective than doing nothing. No one product is better than the other. And in fact, cerumen lytics seem to work better in children, but there's no clear evidence about that. So I always, as good practice, offer earwax softening beforehand. Because I have had clients many times actually by applying just plain old olive oil, not the garlic infused stuff, not the rosemary stuff, but putting 2 drops of olive oil into the ear, rubbing the tragus. I showed this to them. I said, this is what you need to do twice daily, 2 to 3 drops twice daily. By the time they come back to me in 5 days' time, I would say about 30% have automatically resolved by themselves, okay? So really, really consider that and provide really thorough instruction for your clients about the importance of trying this approach. Some clients will actually say, no, I don't want to be about, I need this resolved, okay? And then you have this discussion about risk versus benefit and talk about whether, it's going to be, if it's going to facilitate removal or not. And we'll come back to that a little bit later on. This is suction.
Cerumen removal in high def. Cerumen, otherwise known as earwax, is a waxy oil that's produced by hair follicles and glands in the ear canal. Earwax protects the ear canal and ear from dust, bacteria, as well as from water and infection. However, when earwax builds up and blocks the ear canal, it's the most common cause of hearing loss. Here we are examining the right ear canal. We can see obstructing cerumen laterally. A suction is used at this time to try to remove some.
That's an osteoma right there.
Contents. You can see the skin is very dry. Further in, you see an osteoma superiorly.
We could watch this forever.
Now we use
it's very cathartic. I don't know. Get it.
Earwax lining the canal itself. Since the skin is very dry,
He's causing some abrasions.
very careful.
See that?
To not put too much pressure, which can cause irritation.
And that's with a
as well
curette.
as discomfort.
Yep. So we'll move on, but
Some patients require cerumen removal on a regular basis.
so one of the questions that was about the New Zealand experience and the use. I hear that there's going to be a big move to suctioning in general practice in New Zealand. And I actually would support that. I think that from a safety perspective, if appropriately trained personnel are actually doing suctioning, which I don't do, I think that's something that we could actually do in general practice. But for various reasons, like I work on a remote island with very, very difficult access to ENT services. And we wanted to buy our own little suction device and also get trained up and qualified to actually do that. That's one of those situations where I really want to get training and hands-on experience with an ENT surgeon to actually do this procedure, because you can see the things that he was causing as he was going along. That being said, I think, particularly in remote contexts where we can't fly people off the island for, $3,000 a pop, plus, room and board just to go get their ears suctioned, I think it's actually a really cost-effective thing to train up your staff to appropriately and safely do this. But in New Zealand, they are reportedly actually moving over to ear suctioning. The rationale that I've heard here is that that's actually digging into the pockets of ENT doctors, and that's why we were not allowed to get it, not because we couldn't be trained on how to do it, it was just because there was a conflict of interest there. So quite interesting from that perspective.
There is a GP item number for suction.
Is there really?
Yes.
So do you guys do it?
Yes.
Do you really?
I don't do it personally, but the doctors do, yeah.
Ah. I should contact you later on.
As well, they're advertising for nurses to train up.
Oh.
Have ear suction clinics.
See, this is new information to me.
Yeah, because there's no item number for us to syringe.
Yeah, but it's interesting. Like we were told categorically that we would get in trouble with referrals for other things if we, yeah. Anyway, if you do go down this route of, I would not recommend you do this. This is ear syringing. If you have no other option, go for this approach. The reason why I don't recommend this is because you can't control the pressure. You can do what I did once, and I could, I snipped this piece off right here, attached it to this right here, pressed on the 20 ml syringe, and guess what happened? It flew off. You idiot, Chris. Like, this is the stupid stuff that I do, and I want you guys to learn from my stupid mistakes. So make sure you use a lure lock tip for if you do this approach. I again do not recommend it. I do not recommend ear syringing. I do recommend irrigation if needed. And we'll come back to this a little bit later on. Who here has this device in the clinics? Most of you guys. Who has this device? Yeah. And who's got this device? Really? I hate that device. I had the worst luck with that device. I could never get it out. Really? So you've done it? It's okay? All right. So I had the worst luck with this. So I've worked with all 3 of these devices, and I had the worst luck with that. But somebody needs to teach me how to use it then, because. Was that? I can't hear you guys. Guys, quite.
Just because you have the device doesn't mean that we necessarily rebut it.
Correct. Okay. Do you love it? Which one? This one or this Ranger? I have the worst. I worked on this. I was in the aged care facility, and that's what they had. And I was just. I worked, and I used an entire sink. No, it wasn't that bad. But it was. Yeah, it wasn't that bad. But I just got frustrated with it. I'm sure it works fine with a competent person, but I was practicing outside of my scope of practice at that point. All right. So cautions and contraindications. If you've got a known perforation, ear infections within the last 6 weeks. Each practice will have a different sort of guidance. I think 1 month is sufficient, but 6 weeks is what the literature has been suggesting. Grommets, no history of ear surgery, because once you start doing a tympanoplasty or other surgery, that it's just like getting a wound. Once you get a wound, a chronic wound, and it heals, it's at higher risk of breaking open because the collagen matrix is not as well formed. So if you have a history of ear surgery, I personally would not recommend. I would definitely recommend ear suction with an ENT in cooperative kids or adults if you only have an earring ear. So if that's your only hearing ear, because this one has, for various reasons, I would definitely not ever ear syringe this ear. I would have it instead suctioned. It's kind of like having eye problems. If you've got somebody that has just a conjunctivitis in their only remaining eye, that's actually a medical emergency because it's their last remaining eye. Same thing with the ear, all right? Stenoses will potentiate trapped water in wax. Stenoses potentially can trap water. That's more of a caution as opposed to a contraindication unless they're severe. History of cleft palate surgery, and if they have active symptoms of dizziness or tinnitus, you really have to be careful. And discharge within the last 12 months, and we're talking about purulent discharge as well. If in doubt, grab a colleague. You should always, if you're ever in doubt, grab a colleague. Just be aware that it's not. We were always taught this is cranial nerve 8. It's not just cranial nerve 8 that innervates that ear. You've got cranial nerve 5. You've got the facial nerve. You've got 9. You've got 10. These things, once you trigger them, you can, with either hot or cold water or too aggressive irrigation, or if you've got really bad earwax, it can cause these symptoms. So it's not just cranial nerve 8 that you're worried about, the acoustic nerve. You're actually thinking about sensory issues, mostly because the cranial nerve 7. But there are sensory aspects to most of these nerves right here. But just be aware that it's not just, it's probably one of the more complex innervated organs in the body, in my opinion. We're running out of time. I was going to show, we'll get 10 minutes. This is a really crappy video, but it's about the ProPulse product. And you can find this online. I thought I was going to have so much time today, apparently not, because I've got diarrhea at the mouth. So you can find this online. So if you're curious about this product,
is applied around the patient's neck to ensure they will be kept dry from water and debris.
He's sitting.
The practitioner uses the headlight to ensure full visibility of the ear canal while the irrigation procedure is being performed.
And she goes on to talk more about the temperature of the water. The temperature of the water is critical. It's critical. You need to have body temperature water by the time it hits the eardrum, which means when it's sitting in the reservoir, it should be about 40 degrees Celsius. So by the time that it actually gets down to the actual the person's eardrum, it's about 38 degrees, okay? So just be aware that you really need to make sure that you're looking at the temperature of the water and the forcefulness of the water This is another product that you might not be familiar with. Have you seen this one?
Its unique hydrovac action.
I hate it. Do you love it?
Welch
Do you love
Allen
it?
wash system is designed to safely, efficiently, and neatly remove cerumen. Easy to learn.
This is 7 minutes long. But basically how it works is that it creates a suction at the same time that it's putting water into your ear.
The flexible tubing, the pressure chamber. The tube with the black connector, which will suction out water from the ear during the procedure, should be matched to the black port on the side of the chamber. The tube with the blue connector, which will introduce water into the ear, should be matched to the blue port on the lower side of the chamber. A chamber aerator is also available if you're experiencing a great amount of water splash around your sink. The chamber aerator snugly attaches to the bottom of the pressure chamber. 10 feet of tubing is provided with the system, so you can position your patient just about anywhere in the room with maximum flexibility. The tubing is replaceable to keep your unit new. Next, remove your current faucet aerator and replace it with the ear wash system's snap aerator. Adapters are also included with your ear wash system if needed. And by ordering additional snap aerators from Welch Allen, you can easily make the unit portable, so you can use the ear wash system in multiple exam or procedure rooms. Once the snap aerator is attached to the faucet, the pressure chamber is easily attached or removed. And you can still use your sink normally when the ear wash system isn't attached. To attach the pressure chambers to the faucet, pull down the white plastic ring on the top of the chamber and attach the chamber onto the snap aerator. When the unit is firmly in place, release the white plastic ring. The unit should now be securely attached to your faucet. Placed on inspection.
I'm just going to fast forward this a bit to show you what it looks like. You can again find this video online, and
by healthcare providers and properly trained allied healthcare professionals. Because patients have varying thresholds of comfort during cleaning, it's a good idea to introduce the sound of the ear wash system suction to your patients before the procedure.
so no drape is needed. So there's some advantages and disadvantages to this device. I'm sorry I skipped through the Pro Pulse, but the Pro Pulse is a beating action. I do actually recommend that you look online to see actually how it works. There's actually some pretty funny videos of the Pro Pulse. But with this device, the advantage is the fact that it's actually, there's no drape needed. It's actually a quite clean device. I had trouble controlling the amount of pressure, because you can control with a little thing like, control the amount of pressure with your hand. And I had difficulty controlling the amount of pressure. I prefer the Pro Pulse where you can dial the pressure, personally.
The one really good thing about this one is that it would have worked if the temperature of the water wasn't right. That was perfect.
That's
it was always at the perfect temperature to come out.
what I skipped on here was this device actually has a little indicator that says when it's too cold or it's too hot. And so it actually automatically shuts off when it's too hot. So it's a really cool device from that perspective. Oh, too cold, sorry. Yeah. she's a pro. What I would say about this device, the one thing they don't explain is that little attachment, it doesn't go from room to room. So there's an attachment that you have to use, and you have to attach it to one faucet and one faucet only. Is that what you found as well? Did you have 3 attachment devices? Oh, we didn't. So, all right, yeah, fair enough. So you buy more attachment devices for different rooms. They're cheap. Yeah, okay. This is what I want to talk about real quick, is while we have time. This is the hand syringe, and this is why. Oh, sorry. No, this is. I'll just skip through here. So this is how that hand syringe device that everybody loves, that I clearly don't know how to use. It's got this little disposable silicone tip, which is actually quite comfortable. It sits in there. Squeeze the water. The water is triggered into the device through pumping action. And it comes out, and the wax comes out through these little channels, and the water comes out through these. And there it comes. I love it when it's that big. Look how big it is. Get it. Get it. All right. Moving on. Now, language warning. I do apologize. I've offended people already today. I apologize for that again. However, if you are a bit sensitive about, he's going to say the word shit. So, but let's just talk about this for a second, shall we? Look for things that go wrong.
my, it felt like it was coming out of my eyeball.
This is a colleague that I know in Wisconsin, where I'm from.
Oh, I thought it would be a lot better.
That's still pretty cool.
Is that it? Oh,
Listen to what he says. He coughs.
a little bit, yeah.
A little bit dizzy.
No, but I'm dizzy.
He's dizzy now. Like,
And you're gonna try not to cry. I just washed your brain.
Is there soap in there? Is there bubbles?
it gets worse, but I couldn't believe that she actually published that. I feel terrible for, but it's actually a great way to not ear syringe. All right, we don't have time to do the Slido thing. We're running out of time. Just yell it out. What were some of the things that he was saying or that she was doing that was really problematic? Pain, dizziness. The patient was freaked out. She was just smashing that in there. She's clearly never taken an ear syringing course before, or ear irrigation course before. But the patient was saying things that were setting up massive warning flags saying you shouldn't be doing this, all right? And if you notice, if you truly had an earwax problem, did that amount of earwax, she said, yeah, squeaky clean. Did you see how much, the little tiny flakes in there? It was nothing. Yeah, so, yeah, I don't remember, but she said she cleaned his brain. Yeah, it was a, I really hate to tear down somebody that is obviously proud of the work that they were doing, but make sure that they're sitting down, they can get dizzy, they can get nauseated, they can do a lot of different things. Ensure that the water is at the proper temperature. Consider stopping irrigation. Do stop irrigation. The only time I don't stop irrigation is when they're coughing. I do stop, reassess fully the tympanic membrane, and then if everything is good and they've stopped coughing, I then make sure that I've adjusted my pressure and that I've adjusted make sure my temperature is right, okay? But coughing is usually the only one where I'm like, okay, stop, let's just reassess. But the rest of them, bleeding, ringing, dizziness, pain, let's abort and rethink of our approach. Do we actually need to do cerumen lytics instead? Softening things up. I generally don't use more than 500 mils per ear, and that's actually based on research as well. As far as mitigating risk, making sure you're providing informed consent and documenting that, either verbal or written, is fine. Making sure that you're doing a pre-post examination and documenting that. And then also, when you come up with those high-risk patients that are greater than age 60, that are immunocompromised actively, or if they are diabetic that's really, really poorly controlled, again, this really depends on your individual policies. I personally would be using warmed normal saline instead, okay? There also, as far as pre-softening, I do know that there are some institutions that I've worked for example, where they say you must do 3 days of pre-softening before. That's actually not supported by the literature. They say that if you're going to do cerumen alone, you can do that for 5 days and see how it works. It's better than nothing. But if you are going to be doing ear irrigation, it does definitely help things to pre-soften. The big question, though, is how many days? The research actually indicates 15 minutes beforehand with plain old water will actually be sufficient softening to actually then trigger the actual ear irrigation procedure. So from my perspective, I still send patients home for 5 days because I don't want to do the ear irrigation, even though I really love it when they get those big plugs. I really do want to see if that can work, because it does about 30% of the time in my experience. And if it doesn't, then I know that we're ready to go. But if you've got somebody that says, nope, I must get it done today, I would highly recommend that you have an informed discussion with them, get their ear wet first, just get some water in there, soften it up for about 15 minutes, make sure you're pushing the tragus to push the fluid in there, and then suction them 15 minutes. Actually evidence-based, all right, and safe. What symptoms do you have to consider if the issues of conductive hearing loss don't resolve? The cough doesn't resolve, the tinnitus doesn't resolve, the blocked feeling doesn't resolve. There are, you've got hearing loss, you've got otosclerosis, which is the stiffening of the ossicles. You've got otitis media, you've got medication ototoxicity. There are still medications that we use that can cause ototoxicity. TMJ syndrome, if you've got a lot of pain in the ear, do a quick examination of the jaw and open it and close, and you can see if you can feel or hear audible clicks when you're doing that examination, because sometimes that pain from TMJ or temporomandibular joint syndrome can ready up to the ear and confuse somebody, particularly with chewing. Upper respiratory tract infections and skin disorders like psoriasis, which was mentioned before. That is it. Any questions? 4 o'clock. Yes, go ahead.
Can I just ask one, and it's around the education. So you're suggesting that an OSCE can be developed in practice, and that makes me feel uncomfortable.
Okay, why is that?
In general practice, clinical governance is often missing. So, anybody could put a few things together and it might mean nothing. We need to have some form of a qualified person or somebody that will develop this to ensure that, yes, this is doing what it's designed for. OSCEs in university are validated.
Not necessarily. But yes, I hear what you're saying. There are validated OSCEs. We actually, when we developed our OSCE for our general practices, I used to work in Canberra. We had 9 surgeries across the practice, the region. We developed an OSCE for doing the practical examination, plus the actual, we had a minimum of 5 observed direct observation procedures before they were competent. But we developed our OSCEs based upon, that's what's published online, because there are OSCEs published online for ear examination. Look them up. They've been used, and so look online for published about OSCEs. The other thing that we did as well is that we actually came to a consensus. We actually had, it wasn't me making the clinical governance framework in isolation. I actually went out to consultation. We've got 21 GPs. I had 21 GPs in my practice, and we went to everybody, and we came to a consensus that this was a validated way. That's how you validate it, saying that has face value. So it's not something you develop, though, in isolation.
Yeah, that's very different to just this GP and this person putting something together, what you're saying, initial research.
Yeah.
As well, competency needs to be assessed by a
Senior person.
authorised assessor.
Yep.
Somebody who is qualified as an assessor. And that's a very key, that's an ANMAC standard.
I see what you're saying. I think, though, that are you placing up additional barriers to practice that are unnecessary when, if you have consensus from the profession that is actually being, for example, I have a training, a Cert 4 and training and assessment, right? For the purposes of this, is it necessary? I don't think so. So what I would say is that having a qualified assessor is someone that has been deemed competent. It may not be a GP. It might be another nurse. But I think that the moment that you start saying they have to have an ANMAC qualification, we're talking about vet and TAFE. That's a completely different thing than what we're talking about as far as.
No, ANMAC is the actual education for nurses
Yeah.
in Australia, a different kind of thing. And I get what you're saying. My fear is, and when I did the silly ear syringing course 10 years ago, and it didn't even have a reference. It was just atrocious.
Yeah.
And and I went back, and a GP stood there talking to somebody and said, "Yeah, you're fine."
Yeah, that's what we're trying to get away from.
Yeah, so it's the processes that we need.
And I think that you'll be pleasantly surprised when you actually, when I don't think ANMAC needs to be involved. In fact, they wouldn't be interested. However, when APNA does publish their ear syringing course, I think a lot of the concerns that you're raising will be addressed in their clinical governance. There's actually an attachment that actually comes with it that's actually really good, that actually addresses a lot of the concerns that you're asking. Yes?
Chris, I just want to point out, as you said earlier, you've got to clean those damn things.
Yes! Yeah.
The pulsatile irrigation. I've been to a practice.
Pseudomonas.
What is your process for cleaning it? And they said, you mean you have to clean it?
Pseudomonas. Exactly right. Your governance framework needs to include how equipment, it's actually said that earlier on in the presentation, equipment maintenance. You need to have a process for that. And Pseudomonas is a #1 causative issue for this malignant external otitis. So and particularly in water-based vestibules, like you're talking about, Pseudomonas is a bug. You need to be making sure that you're cleansing it every day. Oh yeah, absolutely. Oh gosh, you guys, I tried so hard. I hope you enjoyed that. Oh, thank you.